So the skin is that first line of defense. It also helps to protect all of those underlying structures that we have. So the epidermis, the dermis, our bones, protects them from damage and from invasion of organisms. We know that any break or any kind of disruption in our skin integrity is dangerous and can possibly be life-threatening depending on how long it's untreated and exactly what happens. So the nurse's role is that we want to be able as nurses to identify risk factors in our patients that are going to predispose them to a break in integrity. So when our patients come into the hospital and we're doing our assessment, we are always looking for ways to prevent things, and preventing skin breakdown is probably one of the most important things that you are going to prevent for your patients, because so much can happen once they get a bed sore. And we're going to talk in depth about all that. We also want to be able as nurses to be able to intervene to prevent or reduce a patient's risk for impaired skin integrity. So when they first come in to the hospital, you know, we're going to do that thorough assessment. We're going to look at all those risk factors that could predispose them to developing some type of a skin issue, but then that assessment really needs to be ongoing. So sometimes by ongoing, I mean, you know, you're going to do it during your shift, the next nurse is going to do it during her shift, but sometimes your patients change throughout your shift and you need to do these other assessments again, because maybe they came in and maybe they weren't feeling great, but they were okay and they were up and they were ambulatory. But then as the day goes on, they start to decompensate a little bit. Now they're not really moving in bed. So what you would do for them in the very beginning of your shift is clearly different than the care that you would be providing them now that they're really not moving. And then we want to be able to provide specific wound care when there is a break in that integrity. So our body's resistance to injury is always going to be affected, we know, by age, the amount of our underlying health issues, our what condition our skin is underneath, if we have acute issues and chronic issues, and what other illnesses we have. We know that our patients have to be adequately nourished and hydrated because we want to protect our cells. Our focus as the nurse is going to be on protecting the skin and maintaining that skin integrity. When we see breaks in our skin, breaks in the integrity in the skin, it can be from multiple things. Maybe it was something we did on purpose. They had a surgery. Maybe it was that they had some type of a traumatic injury. Maybe it was just because they were laying in the same spot for too long. Maybe their skin was too thin. When we think about those older adults and we pulled that piece of tape off from the morning phlebotomy draw and we pulled a layer of their skin off. That happens all the time because our older adults lose that subcutaneous fat and their skin is so thin. So a normal assessment, what we're looking for is our color for our patient is going to be normal and appropriate for their ethnicity. Our temperature should always be warm, not too warm, but not cool. Our skin should be dry. So it should have some type of a moisture, so it shouldn't tent like it would when you're dehydrated, but it's not going to be soaking wet, and it should be dry and it should not be flaky. Every patient should have a skin assessment within each shift, and then we want to make sure that adequate circulation is being maintained because we know how important that is for our body cells. And if you look on in your book, page 1046, table 32.2 talks about all the different factors that put people at risk for developing some type of a skin issue. So we know our skin is a huge protector. It's a barrier to water, organisms in the air, and damaging ultraviolet rays of the sun. It can protect us against infection as long as the skin integrity is maintained. It protects against injury to those underlying tissues and organisms because we have such a nice layer of skin and we have the appropriate thickness and the appropriate amount of subcutaneous fat, but then you always want to think about the babies and the elderly people because they're on the opposite end of those spectrums. And it also prevents loss of moisture from the surface and underlying structures. Our skin also regulates our temperature, so it's going to draw heat from our skin as perspiration occurs and evaporates, and then it's also going to dissipate heat as our blood vessels in the skin dilate. Our skin's able to compensate for cold conditions. It'll constrict our blood vessels to the skin to help diminish that heat loss, and then it also it can compensate for the cold through that contraction of that, what they call those pilomotor muscles that they cause, kind of like those goosebumps, cause the hair to stand up on end and they form that layer of air on the body for insulation. And we also know that we can see radiation and conduction through our skin and evaporation and conduction. So this is a picture of the layers of skin. I got this picture from your book. So we have two layers. We have the epidermis and the dermis. So the epidermis is that top layer right here. It's going to be replaced every 30 to 45 days. Our dermis has all those ridges in it, and that is useful to helping all those ridges kind of run together and help create that unique pattern that we have of our finger and our footprints. We have our subcutaneous tissue, which is the skin that is attached to the muscle, the bone, our connective tissue, and our fat cells. We have melatonin in there, which helps give everybody their skin color. And then the epidermis contains the ridges, like we said, that compromise the fingerprints. So you guys can look at your book and find that picture. So when we talk about temperature regulation, we talked about radiation, conduction, evaporation, and convection. So radiation is going to be when the body gives off heat. So it's a transfer of surface heat into the environment. So an example would be the escape of heat from the surface of warm skin into the cooler air. When we talk about conduction, conduction is when heat moves by motion, which causes cooling. So it's a transfer of heat through contact. Actually, that's convection. I'm sorry, I'm reading the wrong one. I'm reading down here. I put stuff down here in your notes also, and I read the wrong one, sorry. Conduction is the heat transfer to cooler objects. So heat loss is placing a cool cloth on warm skin. You're gonna lose that heat. Evaporation is loss of moisture or water. So we can use diaphoresis as an example. Water on the surface of the body is warmed, and then we have convection, which is the transfer of heat by means of current, liquids, or gases in which warm air molecules move away from the body. So an example would be a cool breeze that blows across the body surface. All right, so our hair is one form of protection that we have. Our hair originates in the dermis. We have something called vellus hair, which is described as woolly or wispy in nature. We can have terminal hair throughout our body in the axillary region, the pubic region. We see it on the face in men. Later, we see it in women as they go through menopause and their hormones start to change. We find it on the arms, the chest, and the legs. It's a much coarser type of hair, and we really don't start seeing that hair on our body till about puberty. Our hair is made by a mixture of keratin and certain amino acids. We know that the hair on our scalp grows the most rapidly, and that by midlife, our hair growth slows down. And then when we get older and our hair stops growing and it turns gray, that is caused by a decrease in melatonin production in our body, which is also why we have so much trouble sleeping when we get older, because of that melatonin. So we have sebaceous and sweat glands. So these are going to be connected to each hair follicle that we have. They secrete sebum, which is a very oily substance. It's a lubricant that helps prevent drying and cracking of the skin and the hair. So it serves as a protector. More active when you're younger and you're going through puberty. You're going to see it more secreted more on your forehead, your nose, your chest, and your back. So I think we can all relate back to when we were teenagers. If we had acne or our faces were breaking out, that's why. And then our sweat glands. So we have equine glands and apocrine glands. So those equine glands secrete water and electrolytes. So sodium and chloride is what is excreted when we are perspiring. And then the apocrine glands secrete fluid during perspiration. So they secrete something called cerumen, which is found around the nibbles, in the angiogenital area region, in the eyelids, in the mammary glands of the breast, and then we can also find them in the external part of our ear canals.
Miss Davis?
Yes.
I thought cerumen was earwax. Or is that? It is?
It is. Yeah, you can find it there. Yeah.
Okay, gotcha.
Yeah.
But it can also be found where you said. Okay, gotcha.
Yeah.
Thanks.
We probably most know it as earwax. That's where we've seen it the most. So we always know that there's developmental considerations. So there's a nice chart in your book on page 1047 that you guys can take a look at. But so for our children younger than 2 years old, their skin is much thinner and weaker than it is in an adult. Infant skin and mucous membranes are very easily injured, and so they're more subject to infection. Children's skin does become increasingly resistant to injury and infection as they grow older. And then when we think of our older aging population, they also have significant skin structure changes. So you see maturation of the epidermal cells is going to be prolonged, which is going to lead to thin, easily damaged skin. We're also losing some of that subcutaneous fat. And then our circulation and our collagen formation are also impaired. That's going to lead to a decreased elasticity and an increased risk for tissue damage from pressure, which is why it's so important that we have these older adults that come into the hospital and they're not moving. They're so susceptible to developing pressure sores. So what are some causes of skin alterations? There's a lot. Obviously, very thin people and very obese people are more susceptible to skin injury. Fluid loss during illnesses can cause dehydration. Skin can appear loose and flabby. We can see when patients have, they're sick, if they have fevers, excessive perspiration can predispose them to skin breakdown. Just from having a fever and sweating and laying in the bed, keeping those damp clothes on, it can cause your skin to break down. Jaundice with people who have liver dysfunction can cause yellow skin that can be very, very itchy and dry. There are diseases of the skin that you guys have probably heard of. So eczema, psoriasis, they each cause their own different lesions that require a certain type of a lotion, and they have to be treated in a certain way. There's always acute illnesses too that you don't have one here, like chickenpox, poison ivy, poison oak, things like that, mosquito bites, spider bites. And there's also a chart for this, page 1046. You can read more. So there's a variety of different diagnostic tests that we can do to evaluate issues with our integumentary system, so we can always use that visual inspection. This is a great opportunity when you're doing your head-to-toe assessment and you're looking, you're listening to their lungs in the back. Make sure you pull that shirt up, look at all the skin on the back, on the front. Make sure when you're checking those pulses, you're rolling up the pants legs, looking at the all the skin. If you're in the room with your patient and they have to go to the bathroom, offer to do it. Don't always defer to the tech. That's a great opportunity for you to watch them walk, see if they're a mobility risk, but you also really get to get a good visualization of their skin. We can do culture and sensitivity tests, allergy tests, Wood's light examination. We're going to talk about these in a couple more slides. Potassium hydroxide test, fungal cultures, and then of course, skin biopsies. So a biopsy, you guys have probably heard of that. It's pretty straightforward. It's just when you go in, usually to a dermatologist, sometimes in the hospital setting, you go in and you have a piece of some type of questionable tissue removed. They go in, they numb the area. They can take some from a needle aspiration, or they can also go in and just cut a small amount out. Sometimes it's not a small amount, it has to be a larger amount, so you might have to get a stitch. Testing for all kinds of stuff, if they're looking for a certain bacteria or a fungus, or if they think it might be cancerous. So always under that local anesthesia, they'll send it off for testing. Obviously, we can use this to confirm or rule out malignancy. And this includes your punch biopsies, where they just go in with this special tool and it kind of like makes a little circle, like a hole punch on top of it. You can do a shave where they shave part of the skin off, and then that excisional biopsy where they actually go in and cut a piece off. We can do skin scrapings. We usually do these if we're looking for some type of fungal issue. What they do is they go in and they take the questionable area and they scrape it with what they call either a scalpel or a blade. Once they scrape all that off, everything they collect is put into a sterile container. They keep it at room temperature, and then they examine it 2 to 3 weeks after to see what type of fungus is growing. This is considered a little bit more invasive, and it also takes a while. So that's a kind of a long time to wait for results, 2 to 3 weeks. Then we have a Wood's light examination. This is when we go in and we examine the patient's skin and hair under an ultraviolet light, usually done in a darkened room, non-invasive. It's used to diagnose fungal infections of the hair and the skin. We can do the potassium hydroxide test, which is used also for fungal infections that don't light up under fluorescent lighting. Again, they go in and they do that scraping, and they're applied with potassium hydroxide, then heated, and then they go in and examine under a microscope to see which type of fungus is actually growing. So when we are doing our integumentary assessment, we want to be very thorough. So when we're looking at our scalp and our hair, we're going to make sure that we have good lighting. We go in and we separate the hair at random areas and inspect the skin. Our hair assessment does not always just apply to our head. We have hair everywhere on our body, so we should be looking at all areas when deemed appropriate. We're going to check the skin. We want to look and see if there's any bruising, any open areas, any redness, any edema. It should be smooth, intact, free of any lesions. We want to look at the color. Is it pink? Is it bright red? Is there hives? Are there spots? What's the texture like? Is it nice and soft and moist within a good moist? I don't mean like soaking wet. Or is it really dry and flaky? And then, you know, abnormal findings would be open areas, lesions, dry skin, bruises, nits or lice, and flaking skin. So we also want to do a good assessment of our patient's hands, their nail beds. So we want to check for normal structure, make sure that all their fingers are there, make sure that all of their, the entire part of their fingernail is there and in good shape, that they're not really thick, they're not really hard or yellow or green. We want to assess for changes in shape or thickness. You know, remember we talked about our emphysema patients that had the clubbing of their fingers because of the oxygenation issue. And then some patients that have iron deficiency can have a concave nail. So those are some things to look at. Our nails have a very hard keratin in them, which serves as, which protects them and helps protect the nail root. Our keratin is found abundantly in our in the blood supply that goes to the finger, and then we call that lunula. So we want to make sure that when our patients come in, each patient every shift gets what's called a skin assessment on what we call this Braden scale. So we use this for every patient, the 99-year-old who is wheelchair bound and the 18-year-old who drove himself to the hospital. This chart serves as an indicator of whether or not our patient is at risk for developing any type of skin issue. This should be done at minimum one time during your shift. Like I said, if things change for your patient, all of a sudden they stop moving, they're not turning as much as they were before, they're sicker than they were before, then we need to do a reassessment. There's been many times during my shift where my patient was moving around on his bed on his own, but then by noon or later in the day, we were making him a Q2 turn because he couldn't reposition himself anymore. So this chart is very straightforward. On the next slide, there is an actual picture of the chart. I'm going to explain a little bit more about that Braden assessment, but it looks at a couple different categories. So it looks at sensory perception. So this is the ability of your patient to be able to sense that they actually need to reposition themselves. It also looks at moisture. So is the patient incontinent? Do they have a fever? How wet are they? All the time. It looks at activity. So what is their activity? Are they out of the bed and walking around the room all the time, or they're not moving at all? And then it looks at friction and shear. And this is your score right here. So if your patient scores a 19 to a 23, they're not at any risk. If they score a 15 to an 18, they're at a mild risk. If they score a 13 to a 14, they're at a moderate risk. A 10 to 12 is a high risk, and then a 6 to 9 would be considered a very high risk. Now, the thing to really think about with this Braden scale is that if your patient is a 19 through a 23 or a 15 to an 18, you just have to watch them. If you're documenting in computer that they're a moderate risk or a high risk or a very high risk, you also have to go in and document what you're doing to protect them. Because at this point, you're stating through your documentation that they are at risk for developing some type of a skin issue. So now you have to go in and say what you're going to do to prevent that. So this is your Braden scale. So I have some stuff down here in the notes that you can read, but we're just going to make it bigger. So here's all your categories. This is your sensory perception, your moisture, your activity, your mobility, your nutrition, and your friction and shear. So what you do is you want to give a number for each category, 1 through 4. So if we look at sensory perception, it tells you this is the ability for your patient to be able to respond to meaningfully pressure-related discomfort. So, if you and I are sitting Indian style on the floor, if our left leg starts to fall asleep, we can sense that and we can just reposition ourselves. Some patients don't have that sensation. So the people that I'm thinking about would be people who have had a stroke. So maybe they have the feeling, but they can't move that lower extremity or that upper extremity, wherever the issue is. Then we have some patients who don't have, who might have the ability to move it, but they don't have the feeling. So our patients that have diabetic neuropathy from diabetes. So what we would do is we would read each of these to decide where your patient falls. So, and we're not going to read every single box for all the categories. I'm just going to read this one. So completely limited would mean that they're unresponsive. They do not moan, flinch, or grasp to any painful stimuli due to diminished level of consciousness or sedation, or they have a limited ability to feel pain over most of the body. So if that described your patient, you would give them a 1 there. 2 would be very limited. So the patient responds only to painful stimuli. They cannot communicate discomfort except by moaning or restlessness, or they have a sensory impairment which limits the ability to feel pain or discomfort over half of the body. And then 3 would be slightly limited. So the patient responds to verbal commands, but cannot always communicate discomfort or need to be turned. And then, or they have some type of sensory impairment, which limits the ability to feel pain to 1 or 2 extremities. And then no impairment at all is responds to verbal command, has no sensory deficits, which would limit the ability to feel or voice pain or discomfort. So it's pretty detailed. If you're not sure where your patient falls, still sometimes I go in and I read each one of these and I'm like, okay, this is more appropriate. They're probably very limited. So you read each one, you give them a number, the appropriate number, and then you total up your score, and then you go back to this risk category here and determine where your patient falls. So once at-risk clients are identified, the nurse is going to implement those measures that reduce conditions to which they could develop a pressure sore. So some of the things that you might implement as a nurse, we're going to promote mobility by turning and repositioning that patient every 2 hours. That's the guideline. Usually I know in my hospital, we have whiteboards that tell us what time we can turn patients. The even numbers go to the right, odd numbers go to the left, and so on. So we want to make sure we're turning them every 2 hours. Sometimes you have a patient that's capable of turning themselves, but maybe they're just sleeping all the time because they're sick, and you just have to go in and prompt them, knock on the door. Hey, Mrs. Jones, it's been 2 hours now. I need you to reposition. You don't want to get a bed sore. So you're either going to do it or you're going to prompt them to do it. And you're always going to document that you did it. If you don't document that you turn them every 2 hours and they end up with a pressure sore, we're going to own it as the facility. And then that's your license. And you don't want to be at fault for having a patient develop a pressure ulcer. So make sure you're taking credit for the work that you do. Keep the patient's skin clean and dry. So if you have a patient that is incontinent, make sure that you try to do toileting when you're in the room. Offer them the bedpan. See if they have to get up. Make sure if they have some type of a brief or an undergarment on, make sure that you're changing that frequently. In our hospital, we are not allowed to use diapers on our patients unless the patients can walk. So the only time we would use one is if maybe we have a patient with liver disease and they have been getting lactulose and they have diarrhea, but physical therapy wants to come work with them. We would put a diaper on them to keep them from having an accident in the hall. We don't want to keep diapers.
Quick question. Sorry. So you're saying in a hospital setting, if they're bedbound at the moment, like they don't wear anything?
No, we don't wear diapers. So what we put under our patients is a blue chalk. We call it a chalk. It's just a big absorbent pad. And we can only put one pad down because the more layers that you put on, it limits the airflow through the mattress and through the room and to that area. So if you have your sheet down and then you have a chalk pad down and then you have a diaper pad, you're limiting that airflow. And then when it gets moist, it's just staying on the skin, it's swelling, limiting that airflow even more. That moisture causes the skin to become red and starts that whole breakdown of the skin. So every facility is different. In our facility, we cannot have them. So we want to make sure we're putting them on a toileting schedule if they need to be. We're checking them frequently, checking that chalk to make sure that if it's wet, we're changing them. If our patient is going to the bathroom all the time and they're peeing, we can put, or if they have diarrhea, something that's going to cause that skin to break down, we can put calmoseptine on them, which is kind of like the adult equivalent of like the baby Desitin that we would put on. It's real thick and it keeps it, it repels that moisture and keeps that skin nice and pink and protects it. You can massage those bony prominences on the patient if the client's skin blanches with pressure relief. So do you know what blanching is? So when we talk about blanchable, it's when we take our finger and usually we do it on the bottom, on the patient's bottom, on their sacral area. You go ahead and you push. And when you let go, like when you push down, it should turn white, but when you let go, it's kind of like your capillary refill. You should see that area turn nice, bright pink again. That's considered blanchable. When the skin does not blanch, that's a problem. That means you're not getting good blood flow to that area. So whenever I have a patient and I'm doing my assessment and I know they don't have good mobility and I'm looking at their bottom, that's the first thing I do is push down to see if it's blanchable or non-blanchable. If it's non-blanchable, it's a problem. That's considered a stage 1. We're going to talk about all the stages of wound care, but that means there's no blood flow to that area right now. So if there's not good blood flow there, then the skin's going to start to break down. So that's the stuff that we want to prevent. by doing our assessments and implementing this good care. So we want to use absorbent pads, those chucks that I talked about. It says, or briefs. In long-term care facility, you will see those briefs, not in most acute care settings, but you want to find something that's going to wick away the moisture from the patients. So, you know, sometimes we have patients who might have a wound in their back or, and they're incontinent all the time. And we want to keep them from peeing, you know, on that area or preventing further skin breakdown. And a lot of people say, well, we should put in a Foley. Well, you don't always have to use a Foley. You have to think outside of the box. So for men, we can use condom caths. So if you have a patient that's going to the bathroom all the time, maybe he's on Lasix and he has a lot of urine output, put a condom cath on the patient. That way it pulls all that fluid away from the skin and helps keep the skin safe. With women, we have something called, they're called Pure Wicks. They're, I don't know how to describe what they look like. If you guys work in a hospital setting now, you'll see them. You'll see them in clinical. They're about this long, I guess, and they're white, and they're like a female catheter. So we put them in, we spread the female's legs apart, and we stick it right there in that area where she pees. We close their legs. This is only good for patients who don't move around a lot. If they move around a lot, it's going to move. And what it does, and we hook it up to suction. So when they start to pee, it just wicks it right away, and it sucks it through the tube and it puts it into the suction container. So that's nice to be able to keep those patients, protect their skin, and it also can give you strict eyes and nose because you really can't do strict eyes and nose on a patient who's bedridden that is incontinent, but this is a good, another alternative to doing that. Make sure you're doing that, applying that topical skin barrier or some type of fecal containment patch when diarrhea occurs. So we do have something called a fecal management system, which is like a Foley for the rectum. So we can put that in there if they're having diarrhea, and it'll go through the tube and collect in this little pouch, help protect the skin. We usually have to do that when patients have C. diff and they have wounds back there because we don't want to get that C. diff in the wound. Make sure we're using a moisturizing skin cleanser for their skin rather than just soap. Apply pressure relieving devices to the heels, those elbows, when they're in the bed and in chairs. So you always want to assess for those prominent bony areas on the patient. Each facility has different things. You can just roll them and put a pillow under them. You can put pillows between their knees. You can put pillows under their, behind their heels so their heels are off the bed. Really just whatever your facility has for you to use. Avoid donut type devices. I haven't really seen them in a long time. I haven't seen them in the acute care setting. It's kind of like a donut type thing where the patient can sit. But their skin, the middle's cut out, but their bottom area can still get, it can deflate and the skin can still touch the seat. So you don't want to use anything like that. Let's see, make sure that we're padding body areas that are subject to pressure. We want to avoid friction. So, which is the effect that causes the skin to rub or break down when it rubs against the sheet or another area. So we talk about friction and shearing. That was on our Braden scale. So a good example is, it says here that it's a physical force that separates the layers of tissue in opposite directions, such as when a seated client slides downwards in the bed or just slides downwards by using a lift sheet and encouraging them to use the trapeze to pull themselves up. So the example I like to use is if you're telling Mrs. Jones to get out of bed, maybe she can stand, but she's a little weak. And if she throws her legs over the side and she puts her hands on the bed and she scoots herself to the end of the bed, that's creating friction and shear on her bottom area and the top part of her legs up against the sheet. So that's what we're talking about when we say friction and shear. We want to make sure we're increasing that dietary protein. Not being proper nourished can cause skin to break down, and it can cause wounds that are already there through surgery or unintentional or intentional reasons to not heal properly. And we want to make sure they're hydrated as well, unless, of course, they have some type of CHF and we're limiting their intake, but still they need to have some hydration. All right. So what are the types of wounds we can have? So we know that a wound is a physical type of injury that causes a break in our skin or our mucous membrane. So when we say intentional wound, that would be a surgical incision. We went in and we intentionally compromised our skin integrity, but for a good reason. So these intentional incisions are always clean and under sterile procedures. When we talk about unintentional, we can also think of them as accidental lacerations or abrasions, puncture wounds. These occur by accident. They weren't planned, and they're usually in an unsterile environment. Because they're at an unsterile environment, they are at a high risk for infection and a healing time increase. Acute wounds, these are, they are always going to heal faster. They're from surgery, or it could also be an unintentional wound that was just an acute, but they're going to be a low risk for infection and they're going to heal the fastest from surgery. Chronic wounds, we usually see these when patients have arterial or venous issues, some type of insufficiency. We also see this with patients that have pressure ulcers. If the patient has a surgery, but they are not very healthy, they have other chronic issues and it's not healing, we're going to see that the edges of the wounds are not approximated, they're not coming together, they're not healthy, it's taking a longer time for healing to occur. And then we talk about, when we describe wounds, we talk about partial thickness and full thickness. So this is how much the dermis and the subcutaneous tissue is destroyed. We'll talk a little bit more about that later. And then we can have an open or a closed type of a wound. So a closed type of a wound is going to be a contusion that's caused by maybe some type of a blunt instrument. It could cause bruising under the skin. You could get a hematoma that's closed, nothing ever comes out. Then we know open obviously is when the skin opens up and there's blood coming out, bones protruding, things like that. An abrasion is the rubbing or scraping of those epidermal layers of skin. A laceration is the tearing and tissue with a blunt or an irregular instrument. And then we might also see an avulsion, which is the tearing of a structure from normal anatomical position. So wound repair, when it does occur, is going to occur one of three ways. We're going to have primary intention, secondary intention, or tertiary intention. So I want you guys to know this. You're going to see this on your test. So when we talk about primary intention, so this is a wound that is healing. Your edges are going to be well approximated, which means that the skin edges are nice and tight, close together. The wound is closed. There's going to be minimal tissue loss. It's going to be sutured with the approximated edges, and it usually heals on its own by primary intention. When we talk about secondary intention, this is where it's not healing as well as it was with primary intention. So those edges of the wound are not very well approximated. You can have large open wounds, such as if you see in patients that have had some type of a major trauma, motorcycle accidents, car accidents, burns, that are going to require more tissue replacement and that are contaminated and infectious. They commonly heal by secondary intention. If a wound that is healing by primary intention becomes infected, it will heal by secondary intention. Wounds that heal by secondary intention take longer to heal and they form more scar tissue. When we talk about tertiary intention, we see a delayed primary closure. So for some reason, that wound is not closing. What happens is that wounds are left open for several days because sometimes we can't skill them right away, because if we do, there's going to be that inflammatory process is going to set in and it's going to cause so much edema. You could have that compartment syndrome or things like that, or we have to keep doing a washout and because we're afraid there's some kind of infection or bacteria is in there, or we're trying to allow some type of a fluid to drain. So whatever the reason is, the wound is left open and then they're closed later. Now, tertiary intention wounds, you're still going to see them progress to that healed state. So you might see a person who had a wound that closed by tertiary intention, but it is healing. So I want you guys to understand that they will all go to that pattern of healing, but they're just going to take longer. Secondary intention, more time. Tertiary intention is going to be left open for a while and then closed. So that delayed, even more delayed healing with the tertiary. All right, so principles of wound healing. Whoops. So we said already, intact skin is that first line of defense against any type of infection or bacteria. Any break in that skin increases our risk for infection. It is extremely careful that we use careful hand hygiene when we're caring for wounds. So before we go in that room, when we're crossing that threshold, washing our hands outside the door with soap and water or the hand sanitizer. When we're gathering our supplies in the room, moving about, before we put on gloves, use that hand sanitizer again. Make sure we put on clean gloves. And then when we're done, make sure we're using hand hygiene again. So that is our biggest line of defense to preventing infection in these wounds, careful hand hygiene. The body does respond systemically to trauma in any area of the body. So we can see an increased body temperature, we can see an increased heart and respiratory rates, anorexia or nausea, even vomiting. We can see musculoskeletal tension and hormonal changes. Our body can tell when something's going around, and systemically we see that carry over into each area of our body. And we know in patients who have an infection, if they have a wound and they get septic, we know what we're going to see, right? We're going to see that high heart rate. We're going to see low blood pressure, fever. That's a sign of sepsis. An adequate blood supply is essential for normal body response to injury. So some people have this and their wounds heal with no issues. When we think about our patients that have those chronic issues, so peripheral vascular disease, coronary artery disease, diabetes, hypertension, right? Things that compromise our blood flow throughout the body. If we don't have good blood supply, our wounds are never going to heal. So what we see when we have an injury is that we see our body is going to send an increased number of those leukocytes, those erythrocytes, and platelets right to that site of injury. We're going to see increased circulation to the injured part because they're going to try to remove all the toxins and the debris and provide that good oxygen-rich blood and all the nutrients that wound needs to heal. So you can look on page 1049. I would recommend that you guys do that. There's good stuff on there that you should know, probably for your test. Box 32.1 talks about good principles of wound healing. So we do have different phases of how a wound heals. So we have homeostasis, inflammatory phase, proliferation phase, and the maturation phase. So just a brief overview, our hemostasis, that is our period immediately after the initial injury. So I'm working out in the backyard and I'm using my chainsaw. I cut my finger off right now. Right now we're in that hemostasis stage. As soon as that injury occurs, our blood vessels are going to start to constrict and our blood clotting begins through platelet activation and clustering. We're not completely blood clotting yet. The process is starting. We don't really see that blood clotting until the inflammatory phase. Our next phase, the inflammatory phase, that lasts about 2 to 3 days. White blood cells, predominantly those leukocytes and macrophages, are going to move into that wound to try and get rid of all the infection and the debris. Our proliferation phase, so this lasts longer. This can last several weeks. This is where the new tissue is built to help fill in that wound space where we lost that other tissue through the injury. And it's primarily that new tissue is going to be built through those fibroblasts. And then we have our maturation phase. So this is the final stage of healing, begins about 3 weeks after injury, and it goes until the wound is completely healed. Collagen in that wound that was just deposited any which way at first, when we started that healing process, is going to be more remodeled, and it's going to help the healing of that area, that wound, become stronger and kind of resemble the tissue that is adjacent to it. So you guys need to know your phases of wound healing. You're going to see questions about that on your test. So this is just a nice little picture that shows you what's going on. So this is your injury right here, your hemostasis and that blood clot. This is the inflammation phase. You can see all the fibroblasts moving in, the macrophages, the blood vessel, and then you're going to see more proliferative and migration of those fibroblasts and that subcutaneous fat. And then you can see how the hematoma is getting smaller and smaller, and you can see finally during the remodeling stage, you've got that freshly healed epidermis. Looks great. Just a little bit left of that hematoma, but compared to before, it looks great. So that is the process. So now we're going to talk about each one in a little bit more detail. So hemostasis, we said, occurs immediately after the initial injury. It is involved with your blood vessels constricting, and blood starts to clot through platelet activation and clustering. After only a brief period of constriction, these same blood vessels begin to dilate, and then we see capillary permeability increase. So this is when those membranes become more permeable. It's going to allow all that plasma and those blood components to leak out of that area that's injured and form a liquid that we call exudate. The accumulation of that exudate is going to cause swelling and pain around that wound. Increased perfusion to that area, because the body knows there's an injury there, is going to result in redness of the wound and that warmth that we feel. And then if the wound is small, the clot loses fluid and a hard scab is formed in an attempt to help protect that wound. And then the platelets are also responsible for releasing substances that stimulate other cells to migrate to the injury to participate in the other phases of healing. So hemostasis is where we start to see that blood clotting process. I want you guys to remember that. The inflammatory phase is where where it continues, where we actually see the blood clotting. So the inflammatory phase follows hemostasis and lasts about 2 to 3 days. Now our blood clotting is really initiated. Those white blood cells, those leukocytes, macrophages move into that wound. The leukocytes get there first. They want to gobble up all that bacteria and all that cellular debris. About 24 hours after that wound, those macrophages, phages are going to enter the wound area and remain for an undetermined extended period of time, as long as they need to be there. They are going to be essential to that healing process. They not only ingest the debris that we see, but they help release those growth factors that are necessary to see all that regrowth of our epithelial cells and those new blood vessels. Are going to help bring good oxygen-rich blood to that area. We're going to see acute inflammation that's going to be characterized by pain. We're going to feel that warmth. We're going to see redness. It could be mild edema. It could be worse than that, but we say mild edema. And we're going to see swelling at the site of injury. We're going to see odorless drainage, okay? During the inflammatory phase, the patient has a generalized body response. So the body's going to react, and we're going to see a mildly elevated temperature. We're going to see an increased number of white blood cells in the blood, and the patient can feel generally fatigued. So what is a normal white blood cell count? What number do we want? Nobody knows this?
Is it 11,000 to 14?
So normal is, well, each facility is different, but normally 5 to 10,000. So anything above 10,000 would tell you that there is some type of infection process starting in the body. So 5 to 10,000. You guys need to know what a normal white blood cell count is, okay? So inflammatory phase, blood clotting is initiated, odorless drainage. Mark it with a star. You guys need to know it. Okay. Proliferation phase. This is known as the fibroblastic, regenerative, or connective tissue phase. This can last for several weeks. Our new tissue is going to be built to fill in that area where the wound was, where we lost all that other previously good tissue. And we're going to see that happen through the action of those fibroblasts. Connective tissue cells are going to synthesize and secrete collagen and produce those growth factors that are going to help induce blood vessel formation, as well as the number and the movement of those endothelial cells. Those capillaries are going to start to grow across the wound. They're going to bring in that oxygen-rich blood and the nutrients that are going to be required for that continued healing process. Fibroblasts form from fibrin. Once they form, they stretch across the area through the clot. And then we're going to see a thin layer of epithelial cells form across the wound, and blood flow across the wound is going to be reinstituted. As the new tissue called granulation tissue forms the foundation for scar development, it's highly vascular. It's very red. It's going to bleed easily. In wounds that heal by first intention, those epithelial cells seal that wound within 24 to 48 hours. When that happens, we don't ever get that opportunity to see that granulation tissue. Collagen synthesis and accumulation continues. It's going to peak around day 5 to 7. Depending on the size of the wound, collagen deposits continue for several weeks or even years, depending on how severe the injury was. By the end of the second week following the injury, most white blood cells have left the wound area. They've done their job, and the wound already is appearing to be lighter in color. Those systemic symptoms that we saw, the malaise, the fever, are typically starting to disappear. During this phase, adequate nutrition and oxygenation, as well as prevention of any kind of strain to the wound or protecting that area, are going to be very important patient considerations. We need that adequate nutrition. We need lots of protein. We need that oxygen-rich blood. Wounds that heal by secondary intention eventually follow the same process, but remember, it takes longer to heal and form that scar tissue. And then we have the last phase, the maturation phase. So this is the final stage of healing. We can call it maturation or remodeling. Begins about 3 weeks after that initial injury occurred. And again, this process can also continue for months or years. That collagen that was just thrown in there initially is going to be remodeled in such a way so that it makes the wound stronger, and it resembles that other healthy, undamaged tissue around that wound. New collagen continues to be deposited, which is going to compress the blood vessels in the healing wound so that the scar and the avascular collagen tissue that does not sweat, grow hair, or tan in sunlight eventually becomes a flat tan line. Scar tissue is going to be less elastic than that uninjured site. So in some people, you might be able to recognize that right away. The strength of the scar tissue is going to remain less than that of the normal tissue. It's never going to be comparable to that healthy normal tissue that we had before. And many years following the injury, it's never restored completely to where it was before. Wounds that heal by secondary intention take longer to remodel and form a scar smaller than the original wound. And if the scar is over a joint or another body structure, it can limit the patient's movement and cause a permanent disability. So we always know that there's going to be factors that affect wound healing. So desiccation is when a patient is dehydrated. We know if we don't have, if our skin's not hydrated and we don't have a good circulating volume, we're not going to be able to get the adequate amount of blood to that wound to help it heal. Maceration, which is overhydration, same thing. Too much fluid, not a good thing. It's not going to promote a good healing environment. Trauma, any kind of repeated trauma is going to result obviously in that wound taking longer to heal. Edema interferes with the blood supply to the area. When it does that, it results in inadequate supply of oxygen and nutrients to the tissue. So we're going to get that delayed wound healing. Any kind of infection, so bacteria in a wound is going to require, the body is going to have to make increased energy to deal with the whole process that's going on in the body. And it can also obviously interfere with wound healing and cause those good cells that are regenerating to die. And then excessive bleeding. So whenever a patient has excessive bleeding, it's going to result in large clots. Those large clots interfere with oxygenation to the tissue. So again, delayed wound healing. And then we see necrosis, which is death of tissue. Obviously, if we see this, healing to the wound is not going to take place at all. And then we have a presence of biofilm. So this is just like a thick layer of microorganisms, bacteria. The results are wound bacteria that grows in clumps. They become embedded in thick, self-made, protective, slimy, in like just this slimy area. It can be on a wound. It can be, we see it in central lines sometimes. We see biofilms there. Patients get, patient comes in and they're septic and they have a central line. That's the first thing we look for. They're very high in sugar and proteins, and it's just like the perfect breeding ground for infection. It's going to decrease the effectiveness of antibiotics, and it's going to impair our wound healing and contribute to chronic inflammation. So when we talked about desiccation up in the top of this slide, we talk about dehydration in the body, but we could also have it down here. There's a picture of, this is the spine, and these are the discs. So for people that have disc disease and a lot of chronic back pain, what happens is these, if you look at the bottom where this healthy disc is, it's in between both of those vertebrae. It's nice and plump. It's not coming out, which would be herniated. It's just perfect. It's filled with lots of fluid. Up here at the top, that's what we call a desiccated disc. So that's when that disc starts to lose all of its fluid. And then what happens is these vertebrae here, these bones are eventually going to be just touching each other. And that's where you get all that chronic back pain from different back issues. All right, so more issues that are going to affect our wound healing. We know age. Children and healthy adults heal much more rapidly. Older adults are more likely to have one or more chronic illnesses with pathologic changes that impede the healing process. Anybody that has circulation and oxygenation issues, they're going to have problems with their wounds healing. So we said in the last slide that adequate blood flow is essential to making these wounds heal in adults and people with peripheral vascular disease, cardiovascular disorders, that hypertension or them diabetes, they do not have that adequate blood flow. So you have to expect that those wounds are going to take longer to heal. Oxygenation of tissues is decreased in people with anemia, because we know if we have anemia, we don't have a lot of numbers, a great number of those red blood cells circulating. So we're not getting a lot of oxygen to the wound. Or patients with chronic respiratory disorders who may smoke. That in smoking is a big issue that causes delayed wound healing. And then nutritional status. So healing requires adequate nutrition. We need adequate proteins, carbohydrates, fats, vitamins, and minerals in the perfect combination. Sometimes just a wound condition. It can just be a specific condition that affects how fast it's going to heal. The health status, so our patients that have that take corticosteroid drugs, you know, that's going to cause delayed wound healing. And then patients who have any type of post-operative radiation therapy. So I'm thinking about these chemotherapy patients, their wounds are going to be very slow to heal because of the radiation. We know our immunocompromised patients also are going to see delayed wound healing. And then those medications, so the corticosteroids, the radiation, and the chemotherapy. So corticosteroids decrease that inflammatory response, right? When someone has an inflammatory response in their body that's uncontrolled, we give them steroids. It calms down the inflammatory response. In wound healing, we want that inflammatory response. We want those wounds to heal. So what patient population, what chronic condition might patients present with where they would be on corticosteroids frequently?
Asthma.
Yes, very good, Dina. Asthma, your asthma patients, your COPD patients. They take the steroids and they take the God almighty, the other inhalers and stuff like that that can compromise their immune system. Radiation depresses the patient's bone marrow function, so it's going to cause a decrease in those leukocytes and an increased risk of infection. If we can't get those white blood cells there, we can't gobble up all the infection and heal the wound. And then our patients who take chemotherapeutic agents. So these agents impair or stop the proliferation of all those rapidly growing cells. Even our cells that are involved in wound healing. It's going to kill all of them. It can't differentiate. All right, so we know we can have complications with various wounds, so we can always develop an infection. So symptoms include purulent drainage, increased drainage. So maybe it was just draining a little bit before, but now it's oozing, it's saturating your dressing, increased or sudden pain, redness, swelling, increased temperature, and increased white blood cell count. So in our purulent drainage, when we talk about that, what is in purulent drainage is white blood cell count, white blood cells, debris, and bacteria. That is what constitutes your purulent drainage, and you guys need to know that. Hemorrhage can place pressure on your surrounding blood vessels and cause tissue ischemia. If we have a dehiscence, so a dehiscence is a partial or a total separation of the wound layers. We can also have evisceration, which is where the abdominal wound, it happens in your abdomen, the abdominal wound completely separates and you have a protrusion of the viscera. So this is where the internal organs come out through the incisional area. If you were to ever go into your patient's room and you were to see that evisceration, you would want to take some sterile water with some gauze, some sterile gauze pads, and cover that whole area. And then contact the doctor, obviously. And then a fistula, which is an abnormal passage. So up here is the fistula right there. You can see it. It's an abnormal passage from an internal organ or a vessel to the outside of the body, or from one internal organ vessel to another. So I've seen patients develop, I saw a lady once who had a fistula from her rectum into her bladder. So every time she would pee, she would actually have stool as well. So just an example of what you guys could see. So if we have wounds, we are probably going to have in some wounds some type of drainage. So you always want to be able to look at your drainage and tell what's coming out. That's going to be an indicator of what's going on with the healing process. So whenever, let me start by saying that whenever you have a dressing on your patient, you have to check it. If they come from the emergency room and they have this beautiful dressing on there that they put on, you cannot say that I'm unable to assess the wound because it's dressed. It is your job as a nurse. If you're going to complete your documentation, you have to see the wound. You have to measure it. You have to identify everything that's going on with it so that you can document it. You have to remove your dressings. It's the only indicator if the wound is healing. If they need a wound consult, do they need a debridement? Is the wound moving in the right direction? If you're not looking at it, it's staying in that dark environment and it can breed infection and it can delay the healing process. So our wound drainage, we can have serous, serosanguinous, sanguinous, and purulent. So our serous drainage is always going to be clear and watery. Sometimes we see this with skin tears, blisters. we see serosanguinous, which is a light pink color. So that's a mixture of our serous and our sanguinous fluid. And then we say our sanguinous is that bright red, fresh blood. And then of course, purulent is that thick, foul smelling drainage with you can just have a varying degree of color. So you can have green, you can have dark brown, you can have yellow, it can be white, it can be blood tinged, it can have brown dots in it. It can just be a mixture of a lot of things. So this is just an example of what you would see. So your serosanguinous right here to the left, that's a mixture of this serous right here. So you can hardly see the serous on there. And this sanguinous here. So this is your serosanguinous. Your serous, this is your purulent, and then this is your sanguinous. So when you come in, whether they have a wound that's been there for a couple of days or they just come back to you from surgery, you're going to look at those dressings. Some dressings you cannot remove. So let me go back a little bit and say that. So sometimes if patients come from surgery, like podiatrists, some abdominal surgeries, some hip surgeries, the doctors want to do that first dressing change, and they'll let you know in the order set not to change it, but you're still going to look at that area to determine if there's any drainage. If it's in an area where you can't change that dressing, if that's the issue, you would want to circle it with a pen, because then when you come back in a couple hours, you want to be able to determine if that area has gotten any bigger. So if you come back in an hour or two and now that drainage has moved outside of that area that you circled, that tells you that there's ongoing leakage, which may be okay. It may be appropriate for your injury, or it may not. They may have to go back to the OR if you're seeing this sanguinous blood that just keeps coming and coming. So if you were to have a dressing that could not be changed, you would just want to reinforce it. Let's see. So these are just some infections. So this up here is just an infected, some type of area with stitches in it. So you can see that sanguinous blood coming out mixed with that purulent drainage. Down here, the bottom left, this is, you can see the redness around it. You can see that yellow purulent drainage on the ends of it. You can see where they circled around it. So they want to determine if that redness goes. Usually we do this when we bring a patient into the emergency room and then before we start antibiotics, because this is how we tell if it's getting worse or better. If it moves to the inside of the line, then we know the antibiotics are helping. If it goes to the outside of the line, it means that it's not healing. This up here is a person's trach. I don't know exactly what happened to the skin there. It looks like they removed skin for a reason, but you can see all that purulent drainage sitting in there. And then this is a very infected wound here that actually has slough on it. So this is actually what we would call, we'll talk more about this, but this would be unstageable. I mean, even though in this case you can see that white strip going through the middle there, that's actually a tendon. But whenever there's any kind of black or slough on there, you can't ever determine what the staging is because you really can't see too much through it. So they would have to go in and debride all that, pull all that off, clean up those edges. So then they could determine what stage that injury actually is, or that wound. So the types of skin breakdown that we can see in our patients. So we can see pressure ulcers or decubitus ulcers. So prevention of pressure ulcers is always nursing responsibility. Say that again. Prevention of pressure ulcers is always nursing responsibility. You are with your patient. You are responsible for making sure that they get turned if they need to be turned. It is something that you can delegate to your tech, but you're ultimately responsible for making sure that it happens. Pressure injury has placed the word pressure ulcer, that's what we used to call it. It used to be he has a pressure ulcer. Now you commonly hear it as pressure injury, still used interchangeably. Some of the older people that have been in the medical field for a long time still say pressure ulcer. It is defined as localized damage to the skin and underlying tissue that usually occurs over a bony prominence. We have a venous stasis ulcer, which comes from venous insufficiency. We have diabetic ulcers that are caused by diuretic neuropathy. And then we have incontinence-associated dermatitis. So these can be prevented by using an incontinence cleanser and a good moisture barrier before damage occurs. So remember, this is that patient who is maybe on Lasix and they have a broken hip and they can't get up to go to the bathroom. So they're constantly urinating and stooling on themselves. So we want to protect that skin. So we're going to make sure that we're using the appropriate incontinence cleanser when we clean them thoroughly in between each pad change. And then we're also treating that that fragile skin with that, what we call calmoseptine, or that moisture barrier, to help keep all that moisture off of them and protect that skin. So what happens during a pressure ulcer? So what happens is we have this external pressure. So it occurs over these, what we call bony prominences, where the patient's body weight is distributed over a very small area without much subcutaneous tissue to help cushion any type of damage to the skin. So we see it on our elbows. We see it on behind our ears where our heads sit. If your patients are really, really tiny and frail, they have poor nutrition or they have failure to thrive, you can see it on the scapulas. You can see it on the heels. You can see it on the knees. You can see it on your sacral area, on that bone at the bottom of your back where your spine is. There's a slide in here that shows you all the little pressure areas. In your book, table 32.4 shows you the common sites that you would see a pressure injury. The most injuries occur over the sacrum, the coccyx, followed by the trochanter, and then the heel. So it causes occluded blood capillaries and poor circulation to the tissue. So you're not getting that oxygen-rich blood to that area anymore. And essentially that area is just basically dying. There's no blood there. Insufficient circulation deprives the tissue of oxygen and nutrients, which is going to lead to ischemia, hypoxia, edema, inflammation, and ultimately you're going to see necrosis, that tissue death, and that ulcer formation. This can occur in as little as 1 to 2 hours if the patient has not been moved or repositioned to allow circulation to flow to dependent areas. So it can happen very, very quickly. Oops. All right, so we talked a little bit earlier in that Braden assessment about friction and shear. So we're going to talk a little bit more in detail about that. So friction occurs when two surfaces rub up against each other. It resembles an abrasion, but it can also damage those superficial blood vessels that are directly under the skin that help deliver all that oxygen-rich blood. So we can see this from a patient who lies on wrinkled sheets. This is why we told you in fundamentals, always make sure that the patient's chuck pad under them, their lift sheet and their regular sheets are all very straight and there's no wrinkles. Skin over the elbows and heels is often injured due to the friction when the patients are lifted and or when they help to move themselves up in bed with the use of their arms and their feet. So if you're repositioning a patient in bed, you can always use your lift. If you have a lift in the room, that's the best thing. It's good ergonomically for you to save your back and your muscles, and it's also good for the patient because you're not pulling them up against the bed when you pull that chuck up to pull them up. If you do have to do that, if you don't have a lift in the room, I always tell my patients to give themselves a hug so their arms come up and their elbows are not laying on the bed when you pull them up. Friction burns can also occur on the back when patients are pulled or slid over sheets when being moved up in bed or transferred onto a stretcher. And then shear is when one layer of tissue slides over another layer. So when shearing happens, it separates the skin from those underlying tissues. Those small blood vessels and capillaries in the area become stretched. They even can tear, which is going to result in decreased circulation to the cells under the skin. Patients who are pulled rather than lifted when being moved up in bed, or if you're transferring them from the bed to the chair or from the stretcher to the bed, are at risk for injury from these forces. A patient who is partially sitting up in bed is susceptible also when the skin sticks to the sheet and those underlying tissues move downward. with the body towards the foot of the bed. This can also happen in patients who sit in a chair, but as they slide down over a period of a couple hours. So this is a great slide for you guys to see. It shows you all these pressure point sites that you probably wouldn't even think about. So you guys can look at that. So we know that there are certain factors that put us at risk for developing pressure ulcers. So we know that aging skin, right? It's thin, it's lost a lot of that subcutaneous fat. It injures sooner. They don't have as much fat on their body to protect those bony areas. Chronic illnesses, coronary heart disease, coronary artery disease, peripheral vascular disease, hypertension, those illnesses where you're not getting that good oxygen-rich blood flow to those areas. When your patients are not immobile, when they're not moving in the bed, when you can't get them out of bed and walk them around, they can't turn over in bed. Those are your patients who are really at risk for developing these pressure ulcers. Malnutrition. So if they are not getting the proper nutrients, their wounds are not going to heal and they're going to lose weight, and those bony areas are going to become more prominent. Fecal and urinary incontinence is going to cause those areas to break down and it's going to cause to make the skin open up. Patients that have altered level of consciousness. Again, if they have an altered level of consciousness, they might not be moving around in the bed like they're supposed to. They might not be using the bathroom like they're supposed to. They may be incontinent. And then our patients that have spinal cord and brain injuries are often left paralyzed and they can't move, reposition themselves. They can't even talk to tell someone how they're feeling, that they need to be repositioned. So we kind of have to think for them. And then neuromuscular disorders. You can look on page 1055, box 32.2, goes over some more. These were just some of the important ones I wanted to talk about. So you guys need to know how to stage a pressure sore. Okay, you're going to see that on your test. So this is how we stage a pressure sore. So we have a stage 1, a stage 2, a stage 3, and a stage 4. A stage 1 is that non-blanchable erythema. So when we go to that area and we push down, and it does not come back that bright red. You're not going to see it go white. It's just going to be non-blanchable. The skin is intact, okay? Stage 1, non-blanchable, skin is still intact, no open areas. Redness, pinkness, skin intact. Stage 2, this is where we see a partial thickness, skin loss with an exposed dermis. So this is going to be like your skin tear. This could even be a blister. You are not seeing any of the underlying structures. And we're going to talk more in depth about these. Stage 3, this would be maybe like a shallow crater with some type of drainage. So it's going to be a little bit more extensive than that stage 2. And that stage 4, this is going to be deeply ulcerated tissue. You're going to have exposed muscle and bone. And they're at a high risk for developing sepsis. So stage 1, non-blanchable erythema of intact skin. Very easy to know stage 1, intact skin, non-blanchable erythema. Stage 2, that's that partial thickness skin loss with exposed dermis. Adipose, which is your fat, is not visible. Your deeper tissues are not visible. Granulation tissue, slough, and eschar, which is black, I'll show you that, is not present. So this is just like your skin. This is just like if you ever saw a skin tear where that first little layer of skin comes off. Then your stage 3, this is your full thickness skin loss. So stage 2 is a partial, stage 3 is a full thickness. Your fat tissue is visible in the ulcer. It is not involving the underlying fascia, their muscle, the tendon, the ligament, the cartilage, or the bone. You cannot see any of those. You may see slough and or eschar, may or may not. Undermining and tunneling may also occur. So undermining and tunneling, this is where, so if you have a circle on a patient that has a wound, and you could go under it with your hand and it can go under the wound. So you could actually touch the top of the back from the underneath. It goes, you can't see it, but it goes under where the wound is and it goes further inside. A stage 3 pressure ulcer requires debridement, usually through surgery. or depending on how bad it is, through wet to dry dressings. You might need that surgical intervention, and sometimes we give them these enzymes on our dressings that will help pull that bad tissue off. So when we talk about wet to dry dressings as a debridement, what we do is we would take an area that had a wound, we would put wet dressing on top of it, put it on the area, cover it with a dry dressing, and then that wound would dry. That dressing would dry. And then as you pull that wound off, you're going to pull all the other yucky, slothy stuff that you don't want on there anymore. Stage 4, this is your full thickness skin loss with extensive destruction. It's exposure of the fascia. You're going to see the muscle, you're going to see tendon, you're going to see ligament, cartilage, or bone in that ulcer. And then it would be unstageable if you can't see if it's covered by slough or that eschar. And eschar is all black. So if you see those in the wound beds, you cannot tell what stage it is because you can't see what's under it. So A, this is your stage 1. Sometimes this can be pink. It can also be like a bruise. It can be red or purple. Right here, stage 2, this is that B. Right here, this is a stage 2. You can't see any fat, you can't see any muscle, no tendons, no bone. Here, this is C. This is your full thickness. This is you can see fat tissue in there underneath all that blood. So right here, you see like this little lip around here. You see how it's kind of sunk in. So that is undermining. If you were to take a Q-tip right where my cursor is and go under here, it would probably go further back under that wound. So that's what we call tunneling when it goes behind that wound. And then here, this is the actual bone. So this is your stage 4. So this can be caused within a week or 2 of not turning your patient. This 1 to 2 hours not turning your patient. Depending on what's going on with their bottom, this could be your patient by the end of the shift if they're peeing and pooping on themselves and you're not taking care of them. Okay, these can cost the hospital upwards of $70,000. That's a lot of money. And this is something that Medicaid, remember these things that Medicaid doesn't pay for? This is one of those things that Medicaid does not cover. When you get into these infections here, these are bad. These can heal, not likely, especially depending on where they are. If they're like in an area where you're stooling, like on the sacrum, which is where we see them when we don't turn patients, stuff's always getting in there. And then what happens is because you always have infections in here, the bone can develop an infection. It's called osteomyelitis. Once you get that, it's not good. People die from osteomyelitis. So it's a serious thing.
Do nurses get in trouble for that?
So I talk all the time about this just culture where we work in an environment that takes things into consideration. Have I ever seen a nurse get in trouble for it? No, I've never seen a person get in trouble. Have there? I'm sure, absolutely, there have been somewhere. If they can prove neglect, they have to be able to prove neglect. With that being said, there are times, I told you that you guys are ultimately responsible for turning these patients, but there's some times where you physically can't ever get back to your patient because you have such a high acuity with your patients that you just can't, you know that patient needs to be changed, but you can't get back there. And if your tech is having a bad shift and they can't get up there, always ask another nurse. I have no problem if a nurse comes to me, even if I'm having a crazy day and says, Trish, I can't turn my patient, can you go do it? Absolutely, I'll take the time to do it. Or you get your charge nurse. And then you just have to document it. Make sure that it's done. If your patient's refusing those, I meant to tell you that too. If they're refusing their turns, make sure you're documenting that too. Because if they're refusing them and then they get one, the hospital doesn't want to have to eat that cost. So good documentation in either way, if you're doing it or you're not doing it and why you're not doing it. So, yep.
Yeah. When you see the wounds, do you have a procedure on how to clean it?
So we'll talk a little bit here, kind of just like an overview of some stuff that we do. It's really, I mean, once you become a nurse, and you're in your facility, you get used to what your facility uses. Every facility uses different things. Some facilities have their own wound care team. They come around, they examine the patient, they look at them, and they build a treatment plan for them. Where we are, we're responsible for dressing these wounds when they first come up. If they come up from the ED and they don't have a dressing or an appropriate dressing, we're responsible for doing that. And there's kind of a learning curve to that, learning which wounds. So if they're dry, you want them to be wet. If they're wet, you want them to be dry. You want to pull, the excess moisture off. But it takes a while to learn. It's something that's not really easy. And then it just depends on your facility, what they use. So, but you will learn to do that as a nurse, yes.
Okay.
So, psychological effects of wounds. So we know that with any type of a wound, there can be pain. We can see an increase in pain when we ambulate, when patients cough, if they're moving in bed, and certainly with dressing changes. So we need to make sure that we are putting into place good interventions that can help our patients be ambulatory, but not in pain. So if we know we're going to do a dressing change and we don't have any pain medicine, I'll call a doctor and say, can I get some pain medicine so I can give to the patient before we do the dressing change? That is just common courtesy. I see doctors that do it, and I've seen doctors that come in and say, we don't have time for pain medicine. I'm on a limited schedule. And I'll advocate for the patient and say, no, this is too uncomfortable. You need to come back, or you need to leave me the orders and I'll do it. Because doctors they forget what it's like, and they come in and they rip these dressings off, and then there's, a whole bunch of blood that they are not nice and easy when they do it. They forget what it's like. And then they do it without pain medicine. And I've heard patients screaming bloody murder before. Please stop, please stop. It's very disturbing. So I always advocate for my patients. If you want them to get up, but they have this wound, give them their pain medicine around the clock if they're willing to take it. Help stay ahead of that pain, because we don't want them to not be moving just because they have an injury. We want to control that pain, keep them ambulating. If they have some type of an abdominal surgery and they have an incision there and they're coughing, we want to make sure they have like a splint or a pillow that they can hug when they're coughing to help take the pressure off of that wound. And then we know anxiety and fear. So we have to be accepting, and we have to express empathy, and we have to be encouraging of the expression of their feelings. We want to answer their questions. We want to be knowledgeable and accurate, and we also want to answer honestly. And we also want to be respectful of when we are looking at wounds or we're changing wounds, that we avoid the exposure of body parts. So make sure when you're in your room, you shut the door so people on the outside can't see. If you're doing, wound care on their leg, make sure you keep their private parts covered up. Just be mindful of those things. And then a change in body image. So we know that this is always going to reflect how the patient feels about themselves. But depending on what type of an injury or how bad the injury is, it can make them feel self-conscious. So we just want to be aware of that and help encourage their self-worth. So pressure ulcer assessments, we're going to look at their risk assessment. That's the first thing we're going to do. We want to know what is their risk of developing an ulcer. Before we can implement anything, we want to know what their risk is of developing an ulcer. You guys need to know that. We want to look at their mobility. Are they able to get up on their own? Are they able to reposition themselves on their own, or if prompted to do so? What's their nutritional status like? Are they NPO? Have they been NPO for a couple days? If they're going to continue to be NPO, we should have something other than IV fluids. They need optimum nutrition to prevent weight loss and those bony prominences, and also to help heal, any wounds. We want to look at their moisture and their incontinence. So are we giving them Lasix and they have a broken hip? So we can put on that condom cath. We can put on that PureWick for the women. How much are they peeing? If they're stooling, are they stooling a lot? Or they have wounds back there? And then the appearance of any existing pressure ulcer. Keep monitoring that throughout your shift. Make sure every time you go in, every 2 hours, you're cleaning that area and putting more Calmoseptine on, or whatever was ordered. And make sure you're doing a pain assessment on your patient. So when we look at that wound, we are assessing for pain. We're looking to see where the wound is on the body, where we want to see the size of it. How big is it? How much of the skin has been compromised? What color is it? Is it red in the base? Is it red around the edges? Is it black? Is it yellow? Is it have purulent drainage? Does it have any type of swelling? Is there any edema? If there is drainage, how much drainage is coming out? Is it thick? Is it thin? Is it clear? Is it green? Does it have a foul odor? Is there any undermining or tunneling? What do those wound edges look like? Are they approximated? Are they not nice? And are they separated and they're all like jaggedy on the edge? And then we want to think about their nutritional status. So these are all the things that we're thinking about together. It's a lot to think about, but these are all the important things that are going to determine the best outcome for our patient. So this is a wound on a heel. So this is a patient that has been laying in the bed that hasn't been moving, or a patient that slides down to the end of the bed. And before something like this develops, you will notice in your patient's heel something that we call boggy. So a boggy heel, if you just reach down and you feel your heel, it's nice, it's firm, it's blanchable, it's warm. In these patients, it's almost like the subcutaneous fat is kind of like separating. There's divots in the skin and it's really squishy. You'll know it when you feel it, that this does not feel right. You can squeeze their heel, like the skin will actually hang sometimes a little bit if they're really boggy, but that's what we call it, boggy, B-O-G-G-Y. If your patients have boggy heels, that's a problem. You need to definitely make sure that if you don't have their heels elevated, that maybe you get, we sell boots, not sell, but we have boots on the unit that will blow up and you can Velcro them to the patient, helps keep their heels off the bed. What I'll see all the time is that some patients or some nurses or techs will put pillows under the heels, but the heels are still on the pillow. Totally defeats the purpose, okay? We want to put those, we want to take the pillows and fold them in half, maybe 3 or 4 pillows. Honestly, if you're really elevating their heels off the bed, you're using 3 or 4 hospital pillows, because hospital pillows are the worst. Or you can even fold up a cover and make sure that it goes right at the base of their ankle, right before it gets to their foot, so that those heels are suspended off the bed. So this this wound right here would be unstageable, because you can't see what's underneath of that. After we go in and we debride it, we could see muscle, we could see the heel bone, tendons, we don't know what's under there. So this right here, you can see is that granulation tissue. You get this little border right here all around the end. This is the epithelial edge of the wound. This yellow right here, this is slough, unstageable if you have this. And then this black that's starting to come in, you've got some here, you've got some here, all around here, that's eschar, again, unstageable. All this has to go in, you have to debride that. And usually what you'll find is a lot of these patients, when they come back from surgery, especially your diabetic patients, they won't even have bleeding from these ulcers. You could take half the foot off and they don't have a lot of bleeding because they don't have a lot of oxygen-rich blood to that area. So bleeding usually isn't an issue. But that's a typical heel wound. Does somebody have a question? Okay.
Yes. So if you catch it at the point where you said it starts to feel mushy, and you start caring for it, you catch it at that point, can you reverse it, or it's probably just going to happen?
No, you don't have, that skin never has to break open. Ideally, you want to get it before it ever even turns pink.
Right.
Once it turns pink, I mean, before it turns pink, you should have them heels elevated. You know they're not moving, we're going to do it. If it's pink, then you want to get the boots. Because usually just, I mean, elevating the heels off the bed, you have to depend that people are going to do it the right way. And like I tell you all the time, I go in and I just see the heels still sitting on the pillow. So I always, if we have them, I try to go to the boots, because I know that even after my shift is up, the heels are still going to be protected. But not every facility has that. But yes, if they're boggy and you start to elevate them, if they get the proper nutrition and they get good blood flow restored to that area, it can absolutely reverse itself. Yep. All right, so we classify our open wounds. We have this color classification. It's RYB. So If it's red, if your wound is red, we're going to protect it. So red wounds are in what we call that proliferative stage of healing, and they reflect that normal granulation tissue that we would expect to see during that healing process. Wounds in this stage need to be protected, usually with some type of a dressing through our nursing intervention. So that's going to be gentle cleansing. So we're not going to go in and scrub it with a toothbrush, but we're going to use sterile water. Sometimes they use normal saline. We're going to use moist dressings, and then we're going to change those dressings only when necessary, on your doctor's orders, and or based on the product of the manufacturer's recommendations. So usually if you have, like sometimes we have a pink foam border that we can put on our patients, and you'll see these in the hospital. Those are good for 7 days if there's no drainage or anything on them, but you still have to pull that dressing off and look at it, okay? It's good for 7 days, but every shift you need to visualize that wound. And then always change it if it's saturated or if it becomes compromised in some way or according to what the doctor orders. So if we have a wound that is yellow, we need to cleanse it. So yellow in the wound can indicate the presence of exudate, which is drainage, or slough, and you have to get it off. These wounds are characterized by oozing from the tissue that's covering that wound, often accompanied by purulent drainage. Drainage can be whitish, yellow, creamy yellow, yellowish green, or even beige. So to cleanse these wounds, we're going to use certain wound cleansers and irrigating fluids to the wound. And this could be just a variety. Every hospital has different things. There's something called Dax that you can use. You soak your dressing in it, you put that in there. Sometimes it's just normal saline. Sometimes it's Santal, which is a thick type of medication that we use that helps debride the wound. So it all just depends on what your facility uses. And then black, well, you know that that's that eschar, and that's unstageable, so we got to get it off. We have to debride it. So black in the wound may indicate the presence of an eschar necrotic tissue, which is usually black, but may also be brown, gray, or tan. The eschar requires debridement before the wound can heal. These wounds are often cared for by advanced practice nurses who are educated in the care of more complex wounds. After debridement, the wound is treated as a yellow wound, and then as the healing progresses towards that red wound. So I don't debride wounds. There are nurses that are specialized to do that, and they certainly can do that in a surgical setting. That's not anything that I've ever done where I actually go in and scrape out a wound. So when we talk about drainage, so you might have a dressing that's dry. You pull that dressing back, there's nothing on it. That's a dry dressing. Clean, dry, and intact is how we would document that. Sometimes we might see scant or minimal drainage. So your wound tissue could be moist, but there's really no exudate. If it was small, your wound would be moist throughout, and there would be drainage on about 25% of the dressing. Moderate drainage would be about 30 to 60% of your dressing would be covered. Large and copious would be your wound tissues are going to be saturated and that the drainage on your dressing is more than 60 to 75%. And then there are some cases where they weigh the dressings to try to determine the exact amount of drainage. Not something I've ever seen done, but it is a practice. So how will we know if our wound has an infection? Well, it can be swollen, it can be deep red in color, it can feel hot when you palpate it or very, very warm. The drainage is increased and it can possibly turn purulent. There can be a foul odor that's noted when you pull back that dressing. Wound edges can start to be separated with dehiscence presence, and then you're going to have some increased pain. Pain that got worse or pain that you already had that you didn't have at all. New pain. So when we measure our wound, this is a very This is a very detailed process. Not a lot of nurses know how to do this. Where I work, we are expected to do this if it's the first time we have a wound. If it's a patient that has a lot of wounds, it can take a very long time. We don't always have time to do it. Wound therapy usually comes and they have a whole kit that they use. But when you measure your wound, you're always going to measure the size of the wound. So you want to measure your parameters. And then you want to know how deep it is. So then you want to document that. And then you also want to determine if there's any undermining, tunneling, or sinus tract. So how far under that wound does it go back into the other areas of the skin? Most, depending on where you work, there's different materials for that. We have cotton ball, really long Q-tips that have cotton edges that have measurements on them that we can use at our facility to determine the depth. And we can also determine the width, and then if there's any undermining or tunneling in there. But those are the things you would want to document: the size of the wound, the depth, the presence of the undermining, tunneling, or that sinus tract. And you can look on page 1062 of your book. Table 32-1 will show you how. So you see how with this picture down here, you can only see a tip of that, you can't see the whole end of that Q-tip. That is tunneling. It's going behind that wound underneath. So there is a tool, it's called the push tool, which is the pressure ulcer scale for healing. It is a quick, accurate tool that was developed for nurses to be able to measure the status of pressure wounds over time. It was designed by the National Pressure Ulcer Advisory Panel, and it has been validated by many people many times over. It's a very accurate assessment. The National Pressure Ulcer Advisory Panel recommends that this tool be used on a regular basis, at least weekly, or whenever the patient or wound status changes. So a great time to do it is during dressing changes, when you're visualizing that wound. The push tool measures 3 parameters that are most indicative of healing. So it looks at the wound size. So whatever the greatest length and the greatest width at the time when it started that was documented. It measures the exudate amount. So you would describe it as whether it's light, moderate, or heavy after the dressing is removed. And then it also looks at the tissue type. So is it closed and resurfaced? Is there epithelial tissue present? Is there granulation tissue present? Any slough or any necrotic tissue, which is going to indicate moving towards something that needs to be debrided or something that is starting to heal. This is not something I've ever used. We don't have it in our facility, but I've seen it in other facilities. So what do we want to do as the nurse? Assess the skin of the clients at risk daily. You have to determine this first in order to determine what interventions you're going to do. That is voted for a reason. You guys need to know that. You want to pay particular attention to those bony areas on the body. You want to make sure you're cleansing that skin routinely, and whenever there's any soiling from a dressing or any type of stool or urine, you want to use a mild cleansing agent. Make sure you're doing just a minimal amount of friction and avoid hot water. A lot of these patients don't have feeling depending on what their chronic issues are, and you don't want to burn the skin. You want to make sure you protect the skin from moisture associated with those episodes of incontinence or exposure to any kind of wound drainage. Minimize the skin injury from friction and shearing forces. So using proper positioning, make sure you're turning them correctly, and using appropriate transferring techniques. We can use lubricants, protective films, dressings, and paddings to help diminish the effects of friction on the skin. Provide dietary intake of lots of protein and calories. Our body needs that in order to heal. Administer nutritional supplements or more aggressive nutritional interventions as needed and ordered. Make sure you're continuing those efforts to improve the patient's mobility and keep them active, because we're going to prevent new wounds from forming. And we want to communicate with other team members regarding the care of the patient. And then you can read on page 1069, table 32.2 has some more information. So some nursing diagnosis that we might see impaired bed mobility related to intolerance to activity, pain, that should say pain, not pin, sorry. Cognitive impairment, depression, severe anxiety, severity of illness, imbalanced nutrition, less than the body requirements, limited to limit access to food, and inability to absorb nutrients due to biological factors or anorexia, acute pain related to tissue destruction and exposure of nerves, impaired skin integrity, stage 1 or stage 2 pressure ulcer related to physical immobility, mechanical factors, altered circulation, skin irritant or excessive moisture, impaired tissue integrity related to stage 3 or 4 related to altered circulation, impaired physical mobility, and excessive moisture. Risk for infection, risk factors, physical immobility, mechanical factors, those shearing, pressure, restraint, altered circulation, skin irritants, and excessive moisture with the open wound, and then a risk for a pressure ulcer. So when we document a pressure ulcer, so my documentation at work, when I document any type of wound, it asks me if it was there at the time of admission. So if you are the first person in the emergency room, or if you are the first person who is assessing this patient when they got to your floor, you want to make sure you document what's called a present on arrival. So these are the things that the patient came in with, because if they came in with a stage 2, we don't have to pay for it if they came in with it. So we have to identify it and properly document it first. Sometimes if I get a patient close to the end of shift and it's just been a crazy day and I can't go in and document all 32 wounds that Mrs. Jones had, I will document a nursing note that goes into great detail where the wounds are, what stages I think they are, how they look, and that'll be my note. That's better than not documenting anything. So you want to evaluate the patient. You're going to document the wound location. Where is it? How much drainage, if any, do they have? What color is it? What size is the wound? How long is it? How deep is it? What's the color of the inside of the wound? What's the color of the skin around the wound? What type of dressing do you have on it? And how did the patient tolerate their treatment? And then reevaluate treatment plan frequently. So if you document that your patient, this is the same thing we were talking about with wounds. If you document that your patient has a non-blanchable area on their right part of their sacrum, you also have to document that you're doing something to fix it. So what did you implement? Did you do Q2 turns? Did you give them camoseptine on their bottom? What did you get them? You have to document that you did something. All right, so we know there are medical and surgical treatments that we can use for certain skin disorders or wounds. So we can give corticosteroids. Sometimes we want to bring down that inflammation. We can give antihistamines. We can do antibiotics, antiseptics. So we can do antibiotics in liquids that we put on certain wounds. Scabicides, depending on if you have like ticks or any kind of skin disease. Particular sides, antisporotic agents. We can do keratolytics. And then when we are treating these wounds, unless it's MRSA or something else, we would just use standard precautions when we're giving these medications over any type of impaired skin area. So just your gloves. You don't have to use a gown or anything like that unless they have MRSA. All right, so medical and surgical treatments. So we can do wet dressings. Wet dressings have a couple different advantages. They are cooling to the wound. They do offer a soothing effect. We used these during surgical procedures for sterile procedures for skin, for certain instances where there's broken skin. We can use a dry gauze placed with a prescribed solution for a certain wound, for a particular wound order. We can also, if we had that abdominal injury where we saw the intestines that were coming out, we can cover some gauze with a solution in that instance. Wet dressings help facilitate the healing process. You guys need to know that, okay? That is the main advantage of a wet dressing. It helps facilitate the healing process. It can help anchor your dressings, and then we can leave them in place until they're dry. And then when we go in and we pull them off, it acts as a method of debridement. So sometimes if you're not debriding them, even if you are, if you can just think of an open wound that has any type of drainage coming out, that has a dry dressing on it, if you can imagine what that would feel like coming off of someone's wound, it's extremely, I've never experienced that, knock on wood, but I just know that it has to be extremely painful. What I like to do is I like to, if I go and I take the top dressing off and I start to look at the dressing that's on the actual wound, I pull it apart very slowly. If there's layers on top, I pull it one layer at a time. I make sure that when I go into the patient's room, I have enough time to spend as much time as I need. This isn't something that I hurry to do in the morning of my med pass. I always decide to do my dressing changes in the afternoon because I know I have more time. If you start to pull that very bottom dressing that's touching the skin up and it pulls the skin with it, it's stuck to it. So what I do is I always make sure I bring some flushes in with me. I take my flush, I squirt that area, leave it for a minute, do something in the room, come back in a minute, and then usually it softens it up. It will still bring that extra tissue off, but it's not like ripping off that new tissue, that new epithelial cells that we want to be there. And it doesn't hurt the patients, and your patients will really appreciate that. We can give therapeutic baths. So for patients, some patients that have chicken pox or certain contact dermatitis or poison ivy, poison oak, things like that. What's the other one that adults get? Shingles, things like that. We can use therapeutic baths for them. Oatmeal baths, no soaps, just warm water. It's a gentle application of some type of a solution to those submerged areas wherever the disorder is. It does help with inflammation, and it also helps to provide itching relief. It helps to aid in the removal of the crust and the scales associated with these different disorders. So like I said, you can have oatmeal baths, cornstarch baths. You can also do it with just baking soda, and we also can do it with mineral oil. We have surgical incision. Sometimes we have to go in. We can do what's called laser therapy. So this is where we have a light amplification by an emission of radiation. It vaporizes wherever the tissue is, and it helps to coagulate the blood vessels. If your patients have this laser therapy done, they have to have some type of an eye protectant on. It can damage their vision. We can do cryo surgery, which is application of a sub-freezing cold with a certain type of a probe that's been dipped in a liquid nitrogen. We do this sometimes with I've seen it done with certain moles. I've seen it done with certain lesions that they that might think if it is, we do it with warts. Some things that if they don't think it's a melanoma, if they think it's a basal cell, sometimes they'll do that and just take it off, and then they'll send it out for a biopsy. After the application at the center of the lesion, the area begins to thaw and it gets kind of like this jello-like appearance on top of it. After that, a scab is going to form. It takes about 4 to 6 weeks for it to completely heal. And then we have, electrodesiccation. This is the use of electrical energy that is converted to heat, which helps destroy or remove any kind of superficial growth on the skin. It actually dehydrates it and causes it to shrink. Also can use this for plantar warts. Certain skin tumors are treated with this method. And then we have some patients, usually our diabetic patients, that don't have that good oxygen-rich blood to get to those wounds. We send them to what's called hyperbaric chambers. It is very expensive, but this is what it looks like. You totally go into this. It's a lot of people can't tolerate it because it's very claustrophobic. They have to put you in here. They shut this door. It's kind of like a vault. And then they put you under, like, they subject you to high amounts of oxygen. So that oxygen gets to the wound. So you can see this patient here on the left, before he went to hyperbaric treatment, that's what his wound looked like. And then after 59 treatments, so 59 treatments sounds like a lot, but it's not. I've seen patients have 100, 120 treatments. If they have to have this in the hospital, if they come from long-term care, they can't go back to long-term care. So they actually stay in the patients, and they actually stay residents in the hospital until they're done this therapy. But you can see how nicely that wound has healed after being subjected to those high levels of oxygen. So that's your hyperbaric oxygen. All right, so it is 8 o'clock. We are a little more than halfway through. How about if we just take like a 5 to 10 minute break, and then we will come back? Okay, you guys want to do that?
Yes, please.
Okie dokie.
Dina needs some time to recover from those pictures.
I know, they are really, they're gross.
Her face was absolutely classic.
Yeah.
Sorry, Dina. Are you okay?
It's funny.
It was
Okay, so some medical and surgical treatment of certain skin disorders. So we can do photochemotherapy. So this uses ultraviolet light plus a special chemical. It's a photosensitizing chemical that, combined with the light, helps to destroy these abnormal cells. We can use it for a variety of different things. Most commonly, we use it for some cancer tumors. We use it for chronic skin conditions like psoriasis, things like that. And then we have lifestyle changes. So tiredness and emotional stress can aggravate certain conditions. So if a patient has herpes or they have psoriasis and they're going through a tough period, working a lot of hours, have a whole lot of stress, it can actually cause those conditions to be worse and cause outbreaks. And then we know that rest, sleep, and diet are important in all factors of all treatment. All right, so when we are cleaning a pressure ulcer, we're going to clean with each dressing change, make sure that we clean it off. Normal saline, sterile saline, whatever the doctor orders. It is a clean technique. It's not a sterile technique. You just want to be very careful when you're cleaning it. You want to do gentle motions. Usually what I do is I just dab. Unless I'm really trying to get something off, then I may dab a little bit harder. You don't just want to minimize pain and trauma. You can use normal saline solution to irrigate and clean the ulcer. Usually what you do is you get a kind of like the syringe that we used on Saturday for the tube feedings. You can get that, and pull it up and clean with that. That's how we usually put it. That's how we usually apply this solution to the wound. And then you're going to want to report any drainage or necrotic tissue, obviously through your documentation, and then to the wound care center or the doctor, whoever's caring for the patient, if it's a change from what was previously documented. All right, so what is the purpose of a dressing? So there's a lot of different reasons why we could put a dressing on a wound. First and foremost, it's a great protectant from any kind of contamination, anything in the outside air. Anytime you have a break in the skin, you obviously want to keep bacteria out, so it definitely can help protect from contamination. It promotes healing by absorbing drainage and debriding that wound when we talked about those moist dressings, those wet dressings. It can also be used as a support or a splint around that wound site. It can produce thermal regulation for that wound surface. It can promote a moist environment. Provide physical, psychological, and aesthetic comfort. Some patients don't want to look at their wounds. Even if they are okay to be open, they don't want to see them. They'll ask you to put a dressing on them. We can use it for debriding to help remove necrotic tissue, to prevent, eliminate, and control infection, to prevent the wound from any further injury, and then to protect that skin surrounding the wound. So these are just some of the types of dressings that you can see in the hospital setting. So this is your transparent dressing here. So you would use this whenever you would want to visualize a part of the wound. We have something like this that doesn't have adhesive on the side that we use for our skin tears. It's called Mepitel, and it has little holes in it, and it is sticky on one side, but we put it over our skin tears, and that way we can visualize them. We can clean them with normal saline because they're perforated. We can put bacitracin through there if we need to. These transparent dressings, like the one that's here, this is more typical of what you would see for your IVs. Because whenever you put in an IV, you want to have a transparent dressing on it so you can see that site where it's going into the skin. We have different gauze dressings. This type of dressing right here in the middle, that big white ball right there, that's called Curlex. We usually do that when we wrap extremities, when we wrap wounds. And then this is Telfa. This is just a type of a bandage that we can use for some of these. They make non-adherent, so it won't stick to the wound. So these are just some surgical asepsis terms that you may see in your book in the clinical setting. Contaminated, we know what that is. It's when something that was clean gets infected. Sterilization, which is the process of making things sterile. Clean technique, so we're not doing things sterile, we're just maintaining like this medical asepsis. They're kind of like the same thing. We're using gloves, washing our hands, that kind of stuff. Disinfection, sterile, dirty. Surgical asepsis, this is what we call sterile technique. And autoclave, that is the machine that we can put equipment into to sterilize it and kill all the bacteria. So this is more types of bandages, just different kind of ways we can apply them. So we can do spiral turns, we can do circular turns where they're right on top of each other. Figure 8, so you're actually making a number 8 with the bandage. The figure 8 ones make for a more secure bandage. We can do spirals or figure 8s for this is when a patient has an above the knee amputation or a below the knee. That's how we wrap the stump. And that's what we call it, a stump. I know that doesn't sound very nice, but that's what it's called, a stump. All right, so we can also put different binders on our patients. So binders or bandages are used to help secure a dressing, apply some type of a pressure or support a wound. So if we use a straight binder, it is probably about this wide and it's pretty long in length. It's made out of elastic. We use this for the chest or the abdomen. I see it a lot in my hospital if we have abdominal surgeries or for patients that have back surgeries. They have Velcro on them. They wrap around the total abdominal area and they're Velcroed. We have what's called a T-binder. I've never seen one of these, but we use them for rectum, perineum, and the groin area. It's where you have a belt that passes around the waist. You secure it and then you pass the tails of it between the legs and then you fasten them to the belt. So if you have a dressing in that area or something like that, it'll help hold it. You can have a sling, which could be used to support an arm injury. And then we have what's called Montgomery straps, which is in this picture here. So these are ties that are attached to an adhesive backing to help hold dressings in place. So if you wanted to change that dressing or look under that dressing, you could just untie it. It's hard to see, but it laces up. You would untie it, you could change that dressing under there and it keeps it intact and then you don't have to keep removing all that adhesive off the patient's skin. And then when we talk about drainage systems, we have open systems and closed systems. So an example of an open system would be a Penrose drain, which is right there on the picture. It's very soft, flexible, easy to manipulate. It does not have any type of collection device. It empties into this absorbent dressing material that surrounds it, and it promotes drainage passively. So it just happens on its own. Then we have a closed system, which you can see in the picture there. So these are your JPEGs, your Hemovacs. These prevent microorganisms from entering the wound, and they allow you to accurately measure the drainage that's coming out in order for suction to be reestablished. So as it starts to fill, you lose suction and I think I have another picture a couple slides down. When you first put it in, you take it, if you have that bulb one, they have them in a bulb and they actually have them in like an accordion where they open up. Either one, whichever one you have to squeeze it together, fold it in half, make it as small as you can so that there's no air in there. And then you have like a little port that you close it with. And then that suction creates a suction in the patient and it pulls all the drainage out. As the drainage starts to fill in these drains, it starts to fill up and you lose that suction. So you have to empty it and then you have to squeeze it again, repeat that whole process again. It has to stay closed and squeeze together real tight in order to create that suction. So this is that Penrose drain. This is the accordion here. It looks just like an accordion. It's very thin when it's squeezed all the way down. When it opens up, it's about this big.
Miss Davis, Cheryl is locked out.
Oh, thank you.
Mm-hmm.
This is actually the drain going into the site. Usually there is a dressing that's covering this because it's held on with a stitch. So it has some type of a dressing there that you need to pull back and look at, make sure there's no infection. This is just a bulb syringe. So you can see there it has that little cap on top of it. You would just squeeze it, fold it in half, put that little cap down, and then it would create that suction. So anytime you have a drain, so these drains are the same thing as your Foleys, any kind of drain or line, your IV, these are all things that have to be documented on in the clinical setting every 4 hours. And as a nurse, you're looking to make sure that you're having accurate assessments. All right, so some topics for home health. So when we send our patients home, so some patients will go home, and if they don't have anyone that can help them at home, they will have home nurse come. Or if the people that live with them at home can't do the dressing changes, they'll have home nurse come once a week, or however often the order is that the thing has to be changed. If they can do it on their own, home nurse will still come and just look at it and drop off certain supplies. And then we could also send them home at the hospital with them till the home nurse comes. So sometimes if they leave on a Saturday or Sunday, home nurse doesn't come till Monday, and then you can just give them some supplies for the weekend. Hold on one second. Oh, sorry. All right. So we want to teach them about infection prevention. So we want to make sure we're monitoring for signs and symptoms, and we want to teach them to tell us what the signs and symptoms are of infection. We want them to be able to recognize it. We want to make sure that they're wearing disposable gloves when they're changing their dressing so they don't contaminate the area and get any infection. We want to educate them about doing proper hand hygiene before and after their dressings. We want to talk to them about making sure that their wound heals appropriately. So we want to tell them the importance of eating those well-balanced meals that have lots of vitamins, that have protein, carbohydrates. We want to encourage them to have good fluid intake, 6 to 8 glasses of fluids a day. And then obviously modifications of daily activity. So this is ultimately going to come back to the discretion of the provider, what type of injury they've had, how severe it is. If they can do little things, maybe they won't be able to run 3 times a week, but if they can take a walk around the block once a day, we still want to keep these patients moving, but within moderation. We want to talk to them about what we expect their skin to look like, what would be normal, how to identify any changes. We want to talk to them about cleaning the wound. So some people think automatically that they can't get a shower at all because they have this wound. Well, it's ultimately up to the doctor and depending on what stage of healing you're at, but certainly after a certain point, you can resume getting a shower again. The thing that you want to think about with cleaning is that you don't ever want to use soap. You just want to use whatever the doctor prescribed or just warm water. And then you want to gently remove any of the crusted areas around the incisional line while you're in the shower or with like some type of a wet dressing, but no soap. Again, that activity and mobility up to the doctor's discretion. You can shower as usual unless the doctor tells you otherwise. talk to them about what their diet should look like, plan out a couple meals with them, have them tell you what kind of foods they should eat, make sure that they're able to control their pain, make sure the doctor gives them pain medicine to go home in, and then teaching them to monitor their elimination. So are they having good urine output? What does the drainage look like? How much drainage are they putting out from their wound? Because this could cause them to lose fluid volume. It could mean that they're septic. It could be a variety of things. So a lot of education. So we can also help manage our patients' symptoms and their pain with hot and cold treatments. So we're going to talk about hot and cold, how we're going to use them, how hot they should be. You want to think about, so whenever you're doing heat and cold, you only want to use them for a certain period of time, give them a break, and then go back to it. Usually the rule of thumb is like 20 minutes on, 20 minutes off. With cold and heat, they are both going to work in different ways. We're going to talk about them. We want to think about your patient's age and their physical condition. So if you have a patient that's a diabetic and they have neuropathy, maybe heat, if they're monitoring themselves and they have a lot of neuropathy, might not be good for them because they can't tell how hot it is. So they might only be able to use cold. And then you want to try and think of the amount of surface area that you have to use if this is even something that's feasible. So when we're applying heat, heat works to help dilate all those peripheral blood vessels. It's going to dilate those blood vessels, increase that blood flow. You're going to get all that oxygen-rich blood and those nutrients to that area. It's going to increase your tissue metabolism. It's going to reduce your blood viscosity, and it's going to increase your capillary permeability. It's going to help to reduce muscle tension, which will help to promote relaxation, and it can help relieve muscle spasms and joint stiffness. It also can help relieve pain because it stimulates specific nerve fibers. When we talked about in pharmacology about that closing the gate that allows that transmission of pain stimuli to actually enter the centers of the brain. So we also have devices to apply heat. So we can use hot water bags or bottles. I don't really see too many of them anymore, but they still sell them, and our older population of people still use them. We can use heating pads, aquatherma pads, which we see in the clinical setting. We have them. We can do hot packs. We can do moist, warm compresses. We can do sitz baths. A lot of these are for our patients who are pregnant. We use them all the time in labor and delivery and post. When you have the baby, if you have any kind of perineal wound, we can do them. And then we can do warm soaks. So when we apply cold, it is going to help constrict, so the complete opposite, constrict those peripheral blood vessels. It can help reduce muscle spasms. It can alter our tissue sensitivity, so it can produce almost like a numbing effect, which can reduce pain. And it can slow the transmission of those pain stimuli. It promotes comfort by reducing blood flow to the tissue and decreasing the local release of pain-producing substances. This action reduces the formation of edema and inflammation. So we can use ice bags, cold packs, hypothermia blankets, and cold compresses to apply moist cold. So some of the things that you want to think about is if it's too cold for a patient or if it's too hot, you can always wrap it in some type of a towel or some type of a cloth to help diminish that a little bit if they say it's too hot. And then you want to do that limited time on, and then 20 minutes on, 20 minutes off is usually what we say. If you have to do a sterile wound dressing, I've never done a sterile wound dressing as a nurse. I'm sure probably in the ICU, maybe they do them. I never have, but this is going to go over a little bit about that sterile technique. So you have to open your sterile package a certain way. A lot of this you're going to learn when we do Foley's. It's kind of similar. So Everything usually comes all wrapped up nice and neat. You want to note the expiration date. You always want to keep the package at waist level. If it goes below the waist or above the waist, it goes out of your visual field. If it's out of your visual field, it can be contaminated. So if you can't see it, you don't know if it's compromised. So it has to stay in your waist level. You open the package on a flat, dry surface. You open the outermost flap first, so the one that's at the top. You touch it just by the very end. You always just try and imagine that that package has kind of like a 1-inch invisible border. That's where you can touch, a 1 inch in. You hold it up, you pull it away from you, making sure that you're not reaching over the kit, and that's how you open all 4 sides of the dressing. Then you do the side flaps. You're going to do them one by one. And then lastly, you're going to do the front flap towards you. You never cross over the top of your sterile field. If you do, you broke sterility. You would have to get a new kit. Never, never turn your back on your sterile field again. Once you lose sight of that field with your eyes, you can't tell if it's been compromised or not. Make sure you only touch the very edges of the package, that 1 inch border, okay? So sometimes you have to add supplies to your sterile field. You should do this before you open your sterile gloves. What you would do is, if you can see this picture of her, she's opening, I don't know what she's opening, but if you say you had a gauze pad and you wanted to add it to your field, you would not put your sterile gloves on, because what you're touching at that point is not sterile if you've just grabbed it from your supply cart. So you would just open it up and then you would hold it over top of your field and then just let it fall in there. So that's what she's doing there. She's pulling back both edges of the wrapper and placing or flipping the item onto the sterile field. So when you are using a new sterile solution, anytime you open it up, you're going to date it, time it, and initial it, because it's only good for 24 hours. After your subsequent uses, during that 24-hour period, it's going to require that you pour off a small amount of that liquid into the trash container before you use it. That's called lipping. And then you pour the solution into your container that's on your sterile field. That'll all make a lot more sense to you when we do Foley's. All right, so next we're going to talk about burns. So dry heat, moist heat, direct contact with hot surfaces, chemicals, electricity, radiation, all of these things can cause burns. When you have a burn, it's going to cause destruction of our skin on a cellular level. It's going to destruct all of our skin layers and all of that depending on how severe it is, the underlying tissue as well. So when we have a burn, we want to kind of have an understanding of what we're going to see afterwards. So if we're taking our skin and we're burning part of our skin off, we're automatically going to have a loss of temperature regulation. So when we talked in the very beginning of this course about all the things that our skin does, you want to kind of think about that, because now everything that our skin does, it's not going to be able to do that. So now we're susceptible to all these issues. So we know that our skin helped regulate temperature. Well, if we lose layers of our skin through a burn, we're not going to be able to regulate our temperature. Our sweat and our sebaceous gland function is going to be compromised, and depending on how far it goes down, even our sensory function. Our metabolism is going to be increased because it's going to have to try to maintain that body heat as a result of all that tissue damage. So when we talk about dry heat injuries, these are going to be open flames and explosives. Contact burns, so this is if we come in contact with a hot curling iron, some type of hot metal, people who lay tar for a living, or grease, like if you're cooking and grease comes up. Chemical burns are going to be when you're exposed to some type of caustic agent. So bleach, drain cleaner. If you're in an industrial setting, a good example is like sulfuric acid. You always want to ask if the burns are related to chemicals, because you have to know what you were subjected to and what certain things you want to look for. So that's important. You guys need to know that. You always want to inquire to see if it was a chemical burn. Electrical burns. So electrical burns are a little different. So this is obviously when you're electrocuted, it could be through lightning. It could just be through, touching some type of a wire. The current's going to pass through your body. So it's going to go through your body, and it can cause severe damage outside, but also on the inside, which we can't see. So you can have a loss of organ function, tissue destruction, cardiac or respiratory arrest. So it's very common, like if a loved one comes in and sees a family member and says, I don't understand why they're so sick. I only see this one little wound here and on their back. So there's usually an entry point and usually an exit point. So to the outside, it doesn't look so much, but because that current follows an internal path, it's going to cause severe damage on the inside. So those patients, their family members are going to need a lot of education about that. And then we can see radiation burns. So these come from therapeutic treatments, from cancer, or even if you get a severe sunburn. Here's some more pictures for Dina. Look, Dina. I actually don't like this. I don't think I could ever be a burn nurse. So these are the different degrees of burn. So we can have a superficial burn, which is also called a first degree. So this is a burn that affects the epidermis and part of the dermis. It's going to be painful. It's going to be pink with red edema, but it's going to subside quickly, and there usually is not any scarring. We can have second degree burns. This is a superficial partial thickness. So this includes the epidermis and the dermis. Your hair follicles are going to be intact. They may appear mottled pink to red. They're going to be painful. You might have blisters. You could even have you could have fluid in there, and it can blanch with pressure. Then you have your second degree, which is your deep partial thickness. So this is a deeper layer of the dermis with damage to the sweat and the sebaceous glands. Variable color, anywhere from patchy red to even white. It can be wet or what's called waxy dry. It does not blanch with pressure, and it is sensitive to pressure only. So you notice as the deeper we go, you start losing your sensation and your pain. So then when we get to full thickness, this is your third degree. This encompasses your epidermis, your dermis, and your subcutaneous tissue. It can be red, it can be white, it can be brown or black. Could have that eschar, which is they describe it as like a leathery covering, and it can be painless. So it's very common for you to see a patient that comes in that could have a third degree burn that's holding a conversation with you, not even aware that they have this burn to the degree that they do, because they don't have any pain anymore because they've had this severe damage to all the layers of the skin. So this is that fourth degree. So full thickness, you're going to have third degree. I just told you what that was. Your fourth degree is your full thickness, epidermis, dermis, subcutaneous tissue, might include fat, that fascia, the muscle, and the bone. It's going to be black, it's going to be depressed, painless, and there's going to be scarring when it heals. And like I said, that patient may be unaware. You can actually see the tendons in that hand. And this poor guy up here, I don't think I could do this for a living. So this is just a picture I grabbed from your book. This just shows you the burns according to your epidermis, your dermis, and your subcutaneous. So if it's superficial first degree, it's just going to be this layer right here. Then that superficial deep partial thickness, it's going to go all the way from the dermis, the epidermis into the dermis. Still full thickness, third degree is still that epidermis and dermis, but it's full thickness. And then your fourth degree is going to include that subcutaneous tissue. You guys need to know your degrees of burns. So this is, actually, I think this is a very disturbing picture. Mrs. Kempsky used these on her slides, and I debated whether I wanted to use them, but I think they show you the extent. So the picture on the left was a person who had to have a face transplant because they were in a fire. And that's horrific. I just can't even imagine. I mean, he can't even see. I don't know if he has hearing. He's got a trach. This is him after the facial transplant. Obviously, he has a lot more surgeries. Over here, you can see these pink areas, the black areas that would help show you the different degrees of the burns. So I have two slides in here, this one and this next one. This is a nice one. So this talks about the different degrees of the burns, the layers of skin that are involved, how it would look, what your healing time would be, and any complications that you're at risk for seeing related to this degree of burn. This here, same thing, but it also talks about whether or not you would see skin grafting with this particular depth classification. And really, it's only in that third degree, that full thickness burn, where you would see that. All right, so the pathophysiology of a burn, it's the immediate initial cause of cell damage from heat. The severity of your burn is always going to be directly related to the temperature of the heat source, so how hot it is, how long the patient had contact with that source, the thickness of the tissue that was exposed to the heat, and the location of the burn. Damage to burns is going to be further compounded. So they're going to have this burn, and then we're going to see all these other changes that are going to make it worse. So just like every other type of wound, we're going to see the activation of that inflammatory process. So this is going to affect those layers of tissue below that initial surface injury. So you're going to get all that inflammatory process go into that site of that injury. You're going to have all those white blood cells. You're going to have all that edema. You're going to see neuroendocrine changes. So these changes you will usually see within the first 24 hours. You're going to see that adrenocorticotropic hormone and that antidiuretic hormone are going to be released because of that stress. So you might see hypovolemia. That's going to cause sodium retention. That retention is going to lead to peripheral edema.
I'm sorry, Miss Trish. Love line got kicked out.
Oh, thank you.
You're welcome.
And then we're going to see this fluid and electrolyte alteration. So when that burn initially happens, fluid from the body is going to move towards that burned area. So we're going to see edema. That fluid is then going to get trapped in this area, and it's going to be unavailable. So remember, we talked about that third spacing. It's still there, but we can't use it for anything. It's trapped. It's unavailable for the use in the body. This is going to lead to intravascular fluid deficit. So we still have this fluid. We have edema in this area, but our blood volume is decreased because it's not in our vascular system anymore. Okay, we learned about that just in homeostasis, so that should still be a little fresh in your mind. Fluid is also lost from that burned area. So usually it's in large amounts because we do have water in our skin. So we lose it in the form of water vapor and seepage. Decreased blood pressure is going to follow because of this whole issue here. We have that intravascular fluid deficit. If not corrected, irreversible shock is going to be likely. That's not a good sign. These changes happen very, very rapidly. Your client's status can change immediately from hour to hour. 1 minute he's fine, the next minute he's not. The patient might present with anemia because the heat is going to destroy those erythrocytes, so we can't make those red blood cells. And then we're going to have, the patient can have hemoconcentration. So this is when that plasma component of the blood is going to be lost or trapped. It's not available for us to use. So our H&H is going to rise because it doesn't have that plasma. So when we have a patient that has burns, we want to try to determine the extent of their burns. I mean, you hear it say all the time in different shows or on the news, over 30% of his body, 10% of his body. So there's a couple ways you can do it. We're going to talk about two. A quick way to estimate how much a client's surface area is involved is to do what we call the rule of nines. So you divide the body into different body parts, and they're in multiples of 9. So you have the front of the face, the anterior part of the head, the posterior part of the head. These are each worth 4.5. You have each arm, the front and the back, each worth 4.5. So 4.5 for the front, 4.5 for the back. The front of the chest here, from the neck down to the pelvic area, is worth 18%. Same thing posterior, neck to buttocks, 18%. The perineal area here is worth 1. Each leg anterior is worth 9. Each leg posterior is worth 9. So what you would do is you could also compare the client's palm with the size of the burn. But we like to do this rule of 9s if we're trying to do it quickly. I need you guys to remember that. If we're trying to do it quickly, we're going to do the rule of 9s. If you're doing the palm is approximately 1% of the person's total body surface area. So you would just see how many times your palm would cover that area. That would equate to 1% of damage. So the best method for calculating burn is in irregular shape, and we want to use this method if you have a patient who has burns that are irregular in shape, and if they're scattered over multiple areas of the body. We would use the palm method. So I thought I had a little problem here. I do. So let's do a practice problem, because you might have to do this on your test. So if you have a patient that has a burn on the back of the right arm, okay, at the back of the right arm, the posterior trunk, the front of the left leg, the anterior head and neck, same thing, and the perineum. Using the rule of 9s, what is the total body surface area that is burned?
37%.
Yes, very good. Good job, guys. That's easy, but you will have to do that on your test. Okay, so you need to know how to do that. There's another second method that you can use. It's called the Lund and Browder method. This is a more exact method of estimating the extent of burn by using specific anatomic parts, particularly the head and the legs. So this over here to the left, this is the rule of 9s. Over here, this is see how they break it down differently. So this area here is 1.5. This upper area is 2. This is 3. The neck is 1. I'm not going to ask you to calculate the Lund and Browder method. I just wanted you to know that there is another way that you can estimate it. And this little chart gives a comparison between the two. The rule of 9s is on the left and the Lund Browder is on the right.
I have a question.
Yes.
We had the that chart on the previous slide. Will that be on the exam, or should we know, like, basically?
No, I'll give you the picture.
Okay, thank you.
All right, so we have 3 phases to burn care. So we have an emergent care, an acute care, and a rehabilitative care. So emergent care is just like that. This is what we call the resuscitative phase. So this is as soon as the injury occurs, and usually goes up until about 24 to 48 hours after the onset of the injury. Our priorities during that time, we are going to make sure that we secure the airway. So some things to think about the airway. If they've been in a house fire or they've been in some kind of a fire where there's smoke, they might not present with injuries right away. Sometimes it takes a few hours before things progress, but always do an examination of the patient's nose and inside the nose too, and check for soot. If they've been in some type of a smoke fire or something like that, you'll see soot inside the nose. That's a good indicator that they've inhaled that, and there's probably damage in the lungs too. So definitely do that. Make sure that you're assessing for difficulty breathing. Make sure, listen to see if they determine any type of stridor, if they develop tachypnea because their breathing's compromised. Just observe for any type of respiratory issues. You're going to do supporting circulation. You're going to give them oxygen. We're going to make sure their organs are perfused by doing fluid replacement. We're going to make sure we're monitoring and managing their pain if they have any. We're going to be doing wound care as ordered because we want to maintain a good wound bed, and we want to prevent infection. And then we want to make sure we're maintaining body temperature, because remember we said if you have burns throughout your skin like that, our skin helps to maintain our body temperature. So patients won't be able to regulate their own temperature. And then we want to provide emotional support because you can imagine how devastating this would be. And then our acute care. So this is 36 to 48 hours after the injury. This is when that fluid shift that we talked about starts to resolve. It's going to end when closure of the wound occurs. Interventions that we're going to make a priority are going to be ventilation. We want to make sure they're good, their respiratory system is good. We're still going to be doing that fluid resuscitation until obviously that issue resolves. These patients may need an endotracheal tube if they have any kind of respiratory failure, or if they have so much damage in their lungs that they can't get air in. They might need a bronchoscopy. They might have to be intubated. They might have to go to hyperbaric oxygen treatment. Remember, we talked about that to help with that wound care. We're going to be giving, probably in this patient, IV analgesics because IV analgesics will work quicker, but they won't last as long. We want to make sure in these patients that we get that tetanus immunization because we don't know what they've been subjected to. Our priorities in the acute phase are going to be assessing the patient, maintaining that cardiovascular stability, making sure their respiratory system is working, GI function. We want to make sure that they're getting nutrition. So they might not be able to eat, they might not have an appetite, but we can do those nutritional shakes. We can give them TPN peripherally. We're going to make sure we are managing these wounds. We want to keep a nice clean wound bed. We want to prevent infection, controlling that pain, and then still taking care of those psychosocial interventions because there's a huge psychosocial component to these burns. And then we have the rehabilitative phase. So this begins when most of the burn has started to heal. It's going to end when the client achieves his or her highest level of functioning possible. Priorities are going to include that psychosocial support, preventing any type of scars and contractures. Remember, we said sometimes if those scars happen over top of a joint, it can cause contractures. And then we want to help them to resume any of their previous activities. This phase can last for years. We're not just talking a couple months, it can be years. So our assessment findings, symptoms, and signs and symptoms, we're going to be looking for any type of a burn, It can be light pink to black skin color. We can see edema, we can see blisters. They can report pain or no pain. They might have compromised breathing if there was smoke involved. We might see symptoms of hypovolemic shock or entrance or exit wounds. So remember we said with electricity or lightning, we can see those exit wounds and the entrance wounds. So it's where does it go in the body and where does it come out of the body? Diagnostic findings. So we're going to do those physical inspections, that head to toe physical assessment. We might need to get an x-ray or a CT of the lungs. And then medical management. Obviously, we're going to take care of all those potential life-threatening complications. So that smoke inhalation injury, hypovolemic shock, any type of infection. Usually, if it's a major burn, you will see that these patients are transported to the regional burn center here in Maryland. They would go to Hopkins. That's where their burn center is. I don't know if University has one or not. I know Hopkins does. All right, so different laboratory tests that we would want to look at during that resuscitation phase. We know, well, we don't know, but you guys will know here shortly when we talk about metabolism, that when our body is under stress, it secretes cortisol. So it's a very, very common finding when patients come into the hospital and they're under some type of a stress due to a medical issue, that their blood glucose level rises. So that is an expected finding. So we might see elevated glucose because their body's under so much stress. Because of that fluid loss, remember we talked about that fluid shift, we're going to see an elevated bun. Our hematocrit and hemoglobin are going to be elevated. And I know you guys are probably confused about this because we're retaining fluid. So I want you guys to, and we can talk more about this if you're confused, but the fluid that we do have edema, but it's not in our intravascular space. okay? It's in that third spacing. It's in other areas of the body. We can't use it. So our intravascular, our circulating blood volume is diminished. That's why the blood pressure is low. Our hematocrit and hemoglobin are in that intravascular fluid, but we don't have any plasma. So we remove all that, and the hematocrit and hemoglobin are now elevated, okay? Because it's not sitting in the plasma. We can't dilute it. So it's due to the loss of fluid and that fluid shift into that interstitial space. I know it's a very confusing concept, but we just will have to keep talking about it. Sodium decreased due to that third spacing, that hyponatremia. And then we're going to see potassium is going to be increased due to that cellular destruction. Remember, where's our potassium at? In our cells, right? Okay, where is our potassium? Nobody answered me.
Inside the cell.
Okie dokie. All right. So at the response to the trauma of a burn, we see that fluid shift. It's going to result in edema. That fluid is trapped, unavailable to the rest of the body. I think, you see my lights flickering? I hope I don't lose power. We're going to see that decreased blood pressure. I want you guys to know that that decreased blood pressure is going to be due to that decreased fluid volume, and it can result in irreversible shock. There's a lot of different shocks. We're going to talk about that next semester, but there is a type of a shock that's irreversible, and then the patient unfortunately does not live. All right, so we know we can have inhalation injuries, so that airway can be compromised. So thermal injuries to the airway can result from steam. We can see them with chemical inhalations that we breathe in. If we aspirate on scalding liquids or any type of external explosive that's in the area while we're breathing. Remember I said these effects might not manifest for 24 to 48 hours. So we're always watching for them. They can include just a scratchy throat. They might sound hoarse. They might have a cough. And then they might start to report, as that swelling sets in, difficulty swallowing. Depending on how far it progresses, you might see drooling. They might have a lot of copious secretions. They might sound very wet. So you're going to have them adventitious breath sounds. You might have expiratory sounds, so wheezes, that stridor. So what are we going to do as the nurse? We're going to support that airway and ventilation. So we're going to administer supplemental oxygen. We're going to be monitoring their pulse ox. We're going to be checking all their vital signs. Check for soot around the nasal passages. And then another life-threatening condition is that hypovolemic shock. So this is your fluid and electrolyte imbalances. So as the nurse, we're going to administer IV fluids and electrolytes as ordered. We're going to monitor those laboratory results, and we want to compare them to the previous data so we can see if things are improving. So looking at those electrolytes, looking at the glucose, looking at the bun, our H&H. We want to assess the fluid volume status. What is the most accurate assessment of our fluid volume status? I'm quitting. Somebody needs to say
daily weights. Daily weights.
Or daily weight or input.
Daily weight, yes, very good. And then these patients are going to be on strict I's and O's. All right, so we can also have an infection from the wound. So burns can leave that skin very vulnerable to certain bacteria, increases our risk for infection and also for developing sepsis. So we as the nurse are going to assess every day, every shift, for discoloration, any type of swelling, redness, odor, warmth, drainage, any fluctuations in the patient's temperature or in their heart rate, because these can be indicative of what? If we see a change in heart rate and temperature. The patient's developing what?
Infection.
Infection.
Yes, but what type of infection? What could that infection have led to and caused?
Sepsis.
Sepsis, yes. So monitor those lab results, observe for anemia and infection, obtain specimens for wound cultures if you need to, administer antibiotics. Sometimes they might be given antibiotics prophylactically I can't talk, it's been too long. Prophylactically to prevent any type of infection. And we're going to use surgical aseptic techniques with these patients when we are doing our dressing changes. We also want to monitor for muscle and joint mobility. So deep burns can obviously cause a change in the movement of our bones and our joints. Not only initially, but as that scar tissue starts to form, it can cause shortening and tightening of the skin and those tendons, which can cause contractures. So we want to encourage neutral positions with our patients with limited flexion. We want to encourage the use of splints to try and prevent those contractures. It will help keep that extremity in the position we want it to be in. Use compression dressings for up to 24 months to help increase mobility and reduce scarring. We're going to talk a little bit more about that. Assist with active and passive range of motion exercises at least 3 times a day to keep them moving. And then, as always, encourage ambulation as soon as possible. So some specific infection prevention measures. So we want to always wash our hands. That's not on here, but it should be. We're going to make sure that we're removing any debris that's in the wound. We're going to be administering those topical antimicrobial medications as ordered. We have something called, when we're talking about dressing changes, we can have an open method or we can have a closed method. So the open method, and you guys need to know this, an open method exposes the burned areas to air. So it's open. We only use this for areas where it's very difficult to apply dressing. So it would be the face, the perineum. Those are pretty difficult places to get a dressing to stay. These patients have to be in isolation in bed with sterile linen because the area is open. So you have to maintain their environment to make it be sterile. It allows a hard crust to form over that partial thickness burn, usually in about 2 to 3 days. Eschar can form in areas that have full thickness burns. And what happens is when that eschar starts to develop, it can get so thick that it can impede circulation. And then they might have to go in and do an escharotomy, which is where they make an incision into the eschar to help relieve that pressure. The closed method, which is opposite of the open method, is the current method, and it is the preferred method. You use a dressing, obviously, and that creates an antimicrobial barrier so that no infection can get to that wound. It discourages hypertrophic scarring, and it provides direct pressure to the wound. You notice how all those things are bolded? You need to know them, okay? The use of these dressings, so they can be non-adherent dressings so they don't stick to the wound. They can be absorbent, so if the wound has a lot of drainage. They can just be occlusive, so we're covering it with some type of a tape. Semi-occlusive. Dressing changes are usually done, it's depending on whatever the doctor orders. It could be every 8 hours, once a shift, twice a day, once a week, whatever they order. And then we have different antimicrobial therapy. So these are, I just named a couple that we see in the clinical setting. So we have Silvadene, which is short for that silva-sulfadiazine, mafenide, and then silver nitrate. There's another one that's called Acticoat, which is a dressing that contains the, it's like a soluble film. It has a coat of silver in it, and it can stay on the burn for up to 5 days. You see this a lot of time in burn units because it helps reduce the pain associated with dressing changes because you're not changing it all the time. This is not anything I've ever seen at my hospital. Sometimes we have to go in and do surgical management of the burn, so we have to go in and debride. These things can be extremely painful. Even just changing these dressings every day, it's extremely painful for the patient going in and pulling off all that skin. I know from just what I've seen, what I've heard from other people, that even the pain medicine doesn't usually help. So you guys have to really think about that. If we have to go in and do it surgically, again, same concept, we're removing that necrotic tissue. try and pre-medicate, obviously. There's 4 ways to do a debridement. So you can do it naturally. So that non-living tissue just dies and it sloughs away from that uninjured tissue. We can do it mechanically where the dead tissue adheres to dressings or it's detached during that cleansing process that we do. We can do it enzymatically through applying those topical enzymes to that wound burn. And we can do surgically. So this is where they go in and use forceps and scissors during dressing changes or wound, and they actually cut off that dead skin and pull it back to show that nice, fresh, healthy skin. Disadvantages, it can cause bleeding. If you already have secondary problems with healing because of some type of pre-existing low red blood cell, that's probably not ideal. And then you can also, at some point during their healing process, you can cover, you wind up covering healthy tissue if you do a skin graft, a temporary skin substitute, or a cultured skin. So you never want to cover healthy tissue. All right, so we're going to talk about skin grafting. So the purpose of skin grafting is to lessen the risk of developing an infection because we're covering that area with a more permanent cover. It's going to help minimize fluid loss. It's going to help with the recovery process. It does reduce the effects of scarring, and then it also prevents a loss of function. Those keratinocytes, it helps those regenerate in that epidermis so the tissue can adhere. You usually do it for deep partial thickness and full thickness burns. When we think about unassisted healing, this is healings that occur without the use of a skin substitute or a graft. These unassisted healings, you see a result in, results are proliferation of that granulation tissue. You'll see that in the wound. You're going to see that it's going to contain those fibroblasts, which help to create those hypertrophic scars. And then you're going to contract and pull the edges of the wound together. Usually that happens, and when it does, it causes an uneven appearance in the healed tissue, and then you can get those contractures. So this picture here is a picture of a person that's had a skin graft, and you can see the outline of where it was. There's still a scar there, but you can see it looks better, much better than it did right here, where all that area is just completely raw. So, they also, the purpose of skin substitutes and grafts, we said they lessen the potential for infection. They minimize that fluid loss, diminish the pain, decrease that granulation of the tissue, promote regeneration of tissue, and prevent loss of function. So there are a couple different types of skin substitutes. You can do a xenograft, which is obtained from animals. So they take it from pigs and cows. You can do an allograft or a homograft. They're both interchangeably used as the same thing. It's a biological source of skin that comes from a cadaver or a donor. And then you can do an autograft, which is the client's own skin that is transplanted from one part of their body to another. Usually you do these in full thickness grafts, or you do what's called a slit graft. We'll talk about that. That's where they pull the fluid, where they pull the skin, the tissue through this little slit in this mechanism that they have during surgery. So you guys need to know these, the type of skin grafts. So again, that autograft is the client's own skin, and it's the best because it's most likely to not be rejected because it belongs to the patient. If we do an allograft, which is the human skin from the cadaver, or the heterograft, which is that animal skin, there's a likelihood that it's going to be rejected because it doesn't belong to the patient. So the types of autografts, we have the split thickness. This is where the epidermis and a thin layer of dermis are going to be harvested from the client's skin. We usually take it from the buttocks or the thighs, so usually those thicker areas. If you do a full thickness, it's going to include the epidermis, the dermis, and then some of that subcutaneous tissue. If we did that slit, this is where they remove the skin from the donor site and they pass it through a little instrument that slits it. It makes it smaller, and then it's thinner, so that way they can stretch it and it can cover a larger area. As with anything else, there are disadvantages. So it's going to compound the pain by creating a new wound. So they have these open wounds already where these burns are, but now they're going to have another wound where they took the skin from. They're going to have to wear pressure garments. We're talking a little bit more about that. And then they're going to have to use sunscreen over that area because you don't want any damage to it.
I'm sorry, Miss Trish. Loveline said her internet kept fluctuating, so she's kicked out.
Say that again.
Loveline, her internet kept fluctuating, and she's kicked out again.
She was just there, but she's not. I'll keep looking to see if she comes back again.
Thank you.
You're welcome. So how are we going to manage these patients from a nursing perspective? Well, we're going to be assessing them, doing that head to toe physical assessment, monitoring those wounds, checking the client status, monitoring those vital signs. We're going to be doing strict calculations, monitoring the infusions that we're putting in, the fluids that we're replacing, preventing, monitoring that hypovolemic shock, which we know can happen and it's a common cause of death. So replacing that fluid is going to be extremely important during that first 24 hours. We're going to try and prevent hypothermia because we know now that some of the skin is missing, it can't control the body's temperature. So our body's going to lose heat. So we're going to use warming blankets and warmers for infusing fluids. If the patient does develop shock, we're going to treat that. So IV fluids, pain relief, IV opioid analgesics. We're going to monitor for respiratory depression. For wound care, we're going to be administering those antibiotics through IV, PO, or maybe in that solution that we're treating the burn or the wound with. We're going to apply those dressings as prescribed, as ordered, monitor them for infection, and then we're going to provide emotional support to these patients because they really need it. And then we're also going to monitor that nutritional support. So we're going to increase their caloric intake to meet the increased metabolic needs of their body. We want to prevent hypoglycemia, increase their protein to help prevent tissue breakdown and promote healing. So client teaching. So they obviously can't get up and exercise like they normally can, but we can do those exercises with them in bed. We can bring their arms and their legs through that range of motion 3 times a day to keep them moving a little bit. If permissible, we can get them from the bed to the chair. And then we have to teach them to wear these pressure garments. So once these patients get these skin grafts, they wear these pressure garments because what it does is it's like an elastic dressing. I'm going to show you on the next slide. And it is really, really tight on the skin. So it puts pressure on that grafted skin and it smooths it out. So it helps prevent the scarring and then the potential for those wound contractures. We want to educate them that they have to wear these pressure garments for at least 23 hours a day. This is a huge deal if you have to wear these. If for some reason the garment is causing discomfort or it's not fitting properly, you want to tell them they have to call the doctor because these need to be snug. Snug fit is needed to help minimize the scarring and an overgrowth of skin. And then, like I said, we want to educate them to have sunscreen because we want to prevent any type of permanent pigment changes in that skin that's starting to heal. So this is the pressure dressing, and depending on where your burns are, you could be wearing something like this from head to toe. So like I said, it does smooth out that grafted skin, reduces scarring, the potential for those wound contractures, 23 hours a day, must be snug, and then they may have to wear this for up to 2 years. This is a huge commitment. This is a long process. So this is some of the diagnoses that we can see: anxiety related to burn injury, disturbed body image related to altered physical appearance, fear related to pain from treatments, deficit fluid volume related to loss of protective skin, hypothermia related to impaired skin integrity, impaired physical mobility related to pain, musculoskeletal impairment and contractures, that imbalanced nutrition, less than body requirements, because now they have that increased metabolic need, right? Or they're not eating and they've had that protein and fluid loss, acute pain and chronic pain related to those burn injuries and the treatments we're giving them, ineffective peripheral tissue perfusion because of the circumferential burns. And then we might see impaired arterial and venous circulation, We might see post-traumatic stress syndrome related to a life-threatening event, risk for ineffective airway clearance, any type of edema or bronchial obstruction, and then risk of deficient fluid volume because we're having that loss of fluid from the skin surface and we're seeing that fluid shift.
Oh, Ms. Davis, I'm sorry. Brian's laptop died. He said he's in the lobby.
Okay, thank you. All right, so just to review, an infection with a burn wound can be life-threatening because of all of the reasons that we talked about. An outcome of a burn injury depends on the initial first aid and the subsequent acute treatment that comes after. And then those 3 complications of burns that can be life-threatening, that inhalation injury, that hypovolemic shock, and then infection.